Hello, my dear future nursing officers. I welcome you all once again back to the master nursing classes. So, I hope everyone is very busy with your MCQ practice and high yield topics revision. So, dear students, don't waste a single minute of the time because these many days, what you have done, that is the a very important thing that is going to matter a lot. And now, what you will going to do, that is going to be a decider. What it will decide, it will decide whether you will be in the selection list or you will be in the out of the selection list, because last few days are very important for us, and here we should not get stagnant in a one particular subject. We have to quickly revise all the golden point that is much and should be necessary for our exams. So please don't get stuck in any one subject, don't get stuck in any one topic, because we have lots of the things to read, revise and practice. So and daily give the mock test, analyze it and move on. Very good evening to one and all. So I welcome you all once again back to the master nursing classes. So this is the very powerful session and having the lots of the important clinical scenario based, concept based questions, plus the special feature, that is the golden point revision. Dear students, the master nursing classes not only training the students with the questions, here we are clearing the concept. And remember, Norcet may or may not repeat the question, but it will repeat the concept. So if you are well know and if you are well confident about the concept, so that is going to be a decider of your rank list. Okay, so I hope everything is going fine, and I hope everyone is practicing the MCQ on daily basis. Okay, especially subject wise MCQs and the daily live test. Don't miss every question you are getting in the Super 60 is the a golden like questions. Okay, so that may having the highest potentiality to directly see in your computer screen in your exam. Okay, yes, so please do keep on practicing the things and don't get distracted, completely be focused. So your focus is your power. So now completely focus on the theory revision, MCQ practice, theory revision, MCQ practice, crash course video and golden point revision. Crash course video, golden point revision. After this one, MCQ practice, theory revision. So this is the 60 days. You have 50 days, you have to repeatedly how to do. So that is only the rank decider. Okay, so I hope everything is clear, and please do subscribe to the channel if anyone are new to the session and all are live to the session. So fatafat hit the like button. We will start the session now without wasting a single minute of the time. So here it comes to the a very important question for you all. So don't read the only one line and decide the answer. So please do read the question completely till the end. So the question body is different and the question what examiner want to ask is the different thing. So please do read it properly. I know only few of you are able to give this one as the correct answer, but this is important and this is very important. Okay, so listen carefully. There is in the 55-year-old man is there. So not man, here is the 55-year-old woman is there. She is having the rheumatoid arthritis and she is taking the oral prednisolone for the last 2 years. Okay, so for the rheumatoid arthritis, so the physician have been prescribed the oral prednisolone. She is taking that one for the last 2 years. Okay, so here is the prolonged history of the steroid use is there. Okay, so taking the steroid for the 2 years is not a joke, but that is going to damage our bone marrow, immunity. Okay, so that is steroid is very dangerous. Getting the point? Yes, sir. So now she is presenting with the back pain, and we have taken the X-ray of the patient and which is showing the vertebral compression fracture. Okay, so X-ray is now showing the vertebral compression fracture. What is the most common cause of the secondary osteoporosis in this patient is the question, beta. The question is, what is the most common cause? These kind of the words are the answer deciding words. So you have to pay the attention on this one. So the question is not asking on the most common cause of the primary osteoporosis. They are asking the question the most common cause of the secondary osteoporosis. Okay, in this patient. So what is the correct answer? So whether it may be a right wrong, so please do involve in the answering the questions. Okay, so immediately putting your answer. So don't watch at the comment box, come to the screen and look at the screen, focus on the screen of your Okay, so on your mobile, right? Yes, so the option is the estrogen deficiency. But estrogen deficiency will causes the osteoporosis or not? Yes. Dear students, estrogen deficiency is going to cause the osteoporosis as a very important, but it is not a most common cause of the secondary osteoporosis. Estrogen deficiency is the part of the primary osteoporosis type 1. I will teach that one. Okay, sir, how estrogen will cause the osteoporosis? Whenever there is the woman is in a reproductive age, she is having the lots of the estrogen in her. So that estrogen is regulating of its endocrine function. Along with that one, estrogen is having the function of making the bone. That is the bone anabolism is done by the estrogen. Okay, estrogen is responsible for the bone anabolism. When after the menopause, means in the post menopausal period, there is suddenly lack of the estrogen, means there is no any process of the bone making, there is no bone anabolism. So bone will start to resorb and bone will start to lose its calcium and its density and its power. So the bone become weak, fragile, and which will causes the fracture also. So the weak, fragile, and the bone with low density, what we call, that is the osteoporosis. Are you getting the point, beta? Yes, sir. So that is the very important. Okay, so here the estrogen deficiency will cause the osteoporosis, but it is not a most common cause of the our secondary osteoporosis. Here it comes to the hyperparathyroidism. Hyperparathyroidism is the cause of the secondary osteoporosis, but it is not a most common cause, as it is given a correct answer is given in the question only. So that is the long term glucocorticoid therapy use. This is the most common cause of the secondary osteoporosis. Very important, right? And vitamin D deficiency also will cause the osteoporosis by reducing the absorption of the calcium. Okay, so let me take you to a beautiful ride on the types of the osteoporosis, and the correct answer for the question which is given above is the option C, and I hope it is very much clear to everyone of you. Okay, yes, now we will discuss the types of the causes of the osteoporosis based on its types. Okay, so here we have the primary osteoporosis. Primary means, so that is not due to the any other external situation. Here it is due to our body physiological situation. That's the primary. Okay, so postmenopausal is the type 1 primary osteoporosis. In the postmenopausal is what happening, there is an decrease of the which hormone, there is decreased estrogen we have. But this decreased estrogen means there is no any bone anabolism, there is decreased bone making process. Okay, so decreased bone anabolism, so increased bone resorption, which will cause the increased bone resorption. Okay, so this will cause the loss of the bone density, and that will this will cause the osteoporosis. Getting the point? Yes, sir. The next is, here we have the senile, means this is osteoporosis is happening due to the decreased osteoblast because of the aging process, where the age is more, the bone forming cells, that is the osteoblast become decreases. So when the osteoblast is decreasing because of the increased age, so that will cause the osteoporosis. We call that one as the senile osteoporosis. So wherever the word senile it will come, so close your eyes and choose the answer towards the aging process. Okay, very important for your exam. So here it is the primary type of the osteoporosis. Next comes to the secondary type of the osteoporosis. This may be due to the external reason, that may be due to other disease conditions, like we are taking the external glucocorticoids or the steroid therapy, or we have the disease conditions like hyperparathyroidism, that one is contributing for the osteoporosis. Means these all are comes under secondary osteoporosis. Here in the secondary osteoporosis we have the glucocorticoids. So these glucocorticoids are the most common secondary cause. Okay, so the steroids, but very important, remember the words. If the patient is using the steroids, we have the lots of the side effect. In that one, the most important side effect we have is the osteoporosis. Osteoporosis. So, what is the nursing intervention to a patient who is using the steroid for the long term? So, don't handle the patient very roughly. So, if we are handling the patient roughly, the bones are soft, there is highest risk of the fracture is there. So, we have to handle the patient very soft and very, we will consider the patient as a fragile to fracture and we will handle the patient. Very important. Okay. So along with that one, if the patient is taking the steroid, there is immunosuppression. There is an immunosuppression. There is an immunosuppression. So if there is a patient is immunosuppressed, and if you are taking the admission to this particular patient to the ward for any other reasons, already patient is on steroid and patient is immunosuppressed, we can't admit this patient with the other general patients. So where we have to admit this patient, sir? We have to admit this one in a positive pressure ventilation room where we have to protect the patient from the another patients. There are the two types of the isolation. One is negative pressure isolation, another one is positive pressure isolation. Listen the concept carefully. So here we have the isolation room. Okay. In this one, we are keeping a patient who is having the immunocompression. Okay. Immunocompromised. Right. And here is the another isolation room. And in this one, we are keeping the patient who is infectious. And who can able to spread the infection to the others. Okay, so here is the patient number B who is having the infections like TB, measles, okay, and other infections where he can spread the infection from him to others. That is the B isolation. And A isolation is there. The patient is immunity is very weak. Patient may having the post transplantation steroid therapy is going on. The patient is a known case of asthma who is taking the steroids from the lots of the days, and the patient may on the other immunosuppressants drugs, or the patient is having the HIV or any other like immunosuppression disease are there. So or the patient who is having the using the steroid for the long term, who are having the very high risk of the infection because their immunity is very low. Okay, so these kind of the patient, we have to keep these kind of the patient in a positive pressure ventilation room. Okay, sir, why in the positive pressure ventilation room? So whenever we will open the door of this room, so that suddenly air will blow from the in to out, and if any infectious agent is coming, so it will go out only. It will not come and meet till the patient. Okay, it will not come and meet till the patient. So there is no risk of the infection to these patients. Okay, yes, sir. And here is the patient number B who is having the measles, TB, like infectious causes there where the patient can easily spread from him to others. Okay, so here we will keep the patient, this particular patient, in the negative pressure ventilation room. Okay, so whenever we will open the door of this room, so it will suck the air from the out to in, so where he will not spread this particular bacteria outside. So he will take the external air inside. Okay, so that will be get exhausted by the exhaust port we will be having in the negative pressure ventilation room. Getting the point, beta? To protect the immunocompromised patient, which protection we will give? To protect the immunocompromised patient, we will give the positive pressure ventilation room. So to protect the other patients with the infectious patients, we will use the negative pressure ventilation room. So I hope it is very much clear. Okay, so along with this one, the steroid is having the very important side effect that is bone marrow suppression. That is the bone marrow suppression. Sir, what happens if the bone marrow is suppressing? Bone marrow is responsible for the bone cell production, means blood cell production. Where the bone marrow is suppressed, no RBC, no WBC, no platelet. No platelet, highest risk of the bleeding. No WBC, again highest chance of the infection. No RBC, anemia will happen. So here we have to take a WBC, CBC, means complete blood count of the patient in a regular interval who is using the steroids. As a very important point to be keep in our mind. Along with this one, this patient is having the highest risk of the infection because his blood glucose level will be high. So increased blood glucose. Okay, increased blood glucose is there, sir. Why, sir? Why? Because this is the glucocorticoids, so which will increase the glucose level. Are you getting the point, beta? By stimulating our adrenaline cortex. Okay, so this is a very important point you have to keep in your mind, right? So here we are having the one very important side effect is the osteoporosis, and this osteoporosis secondary type, that is the most common cause of the secondary osteoporosis is use of the steroids, that is the glucocorticoids. Sir, how it will cause the osteoporosis? Sir, how it will cause the osteoporosis means it will reduces the osteoblast and it will increase the osteoclast. Sir, what is the osteoblast? The bone forming cells are the osteoblast, that is decreased, and the bone destroying cells are the osteoclast, that is increased. So formation is reduced and destruction is increased. There is in the process called as the lysis. Okay, so there is a process called as the degeneration will happens. So always a body will focus on the generation of the things, means making the things. When the things will be going out of the control, there is in the degeneration will start, where the forming cells are reducing, destroying cells are increasing, blasts are reducing, clasts are increasing, the bone degeneration will happen, which will cause the osteoporosis. Along with that one, the steroid will reduces the decreased calcium absorption of the gut. So bone loves to have the calcium. What bone wants to keep with us is calcium. So calcium is the most important thing bone required. Where the steroid is reducing the absorption of the calcium, obviously there is reduction of the calcium in the blood and as well as in the bone also. So, and it will increase the excretion of the calcium through the kidney. So again there is less coming of the calcium and more going up the calcium because of the steroid, so which becomes the most common cause of the secondary type of the osteoporosis. The very important thing to be keep in our mind. Are you getting the point, Buddha? Yes, sir. Next is we have hyperparathyroidism. Sir, what happens in the hyperparathyroidism? So already concept we have discussed. I hope one or two times we have discussed. So just one more time take up thing because it is important. Okay, so what happens in the hyperparathyroidism? We have the thyroid gland. Behind that one we have the four small globules. There is the parathyroid gland, and from the parathyroid gland there is a release of the hormone called as the parathyroid hormone. We will call that one as the sweetie. We will not call that one as a sweetie. We will call that one as the PTH. That's the parathyroid hormone. Getting? So when there is the hyperparathyroidism means increased parathyroidism means the increased parathyroid hormone. So what is the function of the parathyroid hormone? That is the regulation of the blood calcium level. Okay, so PTH will be responsible for the regulation of the blood calcium. How it will regulate the blood calcium, sir? So whenever there is in the balance, okay, so we have the calcitonin, and we have the PTH. Okay, so we have the calcitonin and we have the PTH. So this particular calcitonin, it is responsible for the maintaining the calcium in the bone. Okay, it will maintain the calcium in the bone, and this PTH is responsible for the maintaining the calcium in the blood. Okay, it is responsible for the maintaining the calcium in the blood. Okay, and this PTH also normal, calcitonin also normal, means blood calcium level also normal, bone calcium level also normal. But when there is an increased PTH, what it will do? It will take a calcium from the bone into the blood. Okay, it will take a calcium from the bone into the blood. Okay, so that time calcium is still normal only, and it is having the hyperactivity, means the bone will start to resorb. Because the calcium which is going out of the bone. Okay, so calcium which is going out of the bone means bone will start to degenerate. Okay, so that will cause us the osteoporosis. I hope the concept is clear and very clear to every one of you. Are you getting that point, Peter? Yes, sir. The next is we have the another cause of the osteoporosis, that is the malabsorption or the deficiency of the vitamin D. Sir, what are the situation where the vitamin D deficiency may happens? Where the person is not exposing to the sun rays, where the person is not having the calcium through the oral intake. Okay, sorry. Vitamin D. Okay, so which may cause the decrease of like having the vitamin D or the not exposing to the sun rays, which will cause the vitamin D deficiency. So here the vitamin D is reduced, means vitamin D is responsible for what, sir? Vitamin D is responsible for the absorption of the calcium, and it will responsible for the reabsorption of the calcium from the kidney. It will not allow the calcium to get excreted out of the kidney. Vitamin D will absorb the calcium from the GI system, and it will reabsorb the calcium from the like from the like from the kidneys, okay, it will not allows the excretion of the calcium, where it will maintains the calcium. Okay, so vitamin D is decreasing here because of the vitamin D is deficiency or vitamin D malabsorption, because the patient is not exposing to the sun rays, because the patient is not having the sufficient amount of the vitamin D in the food, so which will causes the decreased vitamin D. Decreased vitamin D means there is decreased absorption of the calcium. So when the calcium is not there, that time what happens, there is in the stimulation which goes towards the stimulation which will goes towards our parathyroid gland. So this particular parathyroid gland, what it will do, this particular parathyroid gland will be get stimulated, means the PTH will get increases, because the blood calcium is maintained by which hormone? PTH hormone. Here there is a stimulation which is going towards the parathyroid gland, that the blood calcium is reduced. So that time what happens, the parathyroid hormone will start to compensate, and it will comes and it will damage the bone, and from the bone it will take the calcium towards the blood. Okay, so this is how the PTH is responsible for the maintaining the calcium, and this is how when the PTH is increasing, the bone will get degenerate because of the loss of the calcium. Getting the point? So here, due to the secondary increased PTH, okay, so there is in the bone resorption will start. So bone resorption means bone regeneration, so that is going to be a osteoporosis. Here it comes to the next very important point. So you must and should remember better, when the patient is immobilized, there is the highest risk of the osteoporosis, there is a highest risk of the deep vein thrombosis, there is highest risk of the blood sore, okay, and there is highest risk of the kidney stones. So these are the very important 4 points you have to keep in your mind. Sir, why the immobilization will causes the osteoporosis? That is due to the disuse syndrome. When we will not use our bone at a correct time, correct rate, correct work, so the bone will start to atrophy. So because we are using our bone, we are working with our bone, means that time only the osteoblast will be stimulated, that time only bone forming process will be regulated. If we are not using the bone, there is reduce of the osteoblast. The reduce of the osteoblast means there is no formation of the bone, and bone will start to lose the calcium also. So where there is the disused atrophy of the our bone will happen. Getting the point? Yes, sir. So the immobilization is the very dangerous thing. Okay, so always that is the reason we have to keep on moving the patient. Even if it is the bedridden, we will encourage for the passive range of the motion exercises, isovolumetric exercises, that is recommended to in order to prevent this osteoporosis and all. Okay, yes, sir. So when there is the patient is having the immobilization, so that time I told there is in the resorption of the bone, and resorption of the bone means the calcium in the bone is reducing, calcium in the blood is increasing, so that calcium will goes and deposits in the kidney. So there is in the calcium phosphate stone may increases. So that is also a very important point. Immobilization increases the risk of the kidney stones, immobilization increases the risk of the osteoporosis. And which one point I told, that is the immobilization increases the risk of the pressure sore, and immobilization will increase the risk of the deep vein thrombosis. You know, in the virtuous triad of the risk of the DVT, we have studied that there is endothelial injury, there is in the stasis of the blood, okay, so and hypercoagulability. So where the stasis of the blood means patient is immobile, not moving, means the flow of the blood is not perfect. So the flow of the blood is not perfect means the blood will stay in a one particular situation, where in the immobilized patients the circulation is inappropriate. So circulation is compromised because there is the flow is not perfect. So the DVT risk also will increase. Yes, let me repeat again the 4 very important in the history of the question. In the question they have given the immobilization. Think about these 4 things as a priority. So that is DVT and kidney stone and osteoporosis, and very importantly, which one? Bed sores. Okay, so I hope it is clear to every one of you, right? So there is immobilization means no weight bearing on the axial or the appendicular skeletons. No weight bearing means there is no stimulation to the osteoblast. So osteoblast stimulation is not there means osteoblast will not form. Osteoblast will not form means bone will not form. So the bone resorption becomes the predominates, and the which will cause the very important points to be keep in our mind, that the resorption of the bone and the osteoporosis. Okay, so these are the important and very important causes of the osteoporosis. Not only we have discussed the causes of the osteoporosis, all 360-degree points that is to be keep in our mind, and we have to approach the question with the integrity. That one I have told here in the perfect and very perfect manner. This is what you are learning the concept, and this concept are going to make you a champions. Believe in the concept, not in the questions. So yes, question will help us to understand the concept. That is the reason we are taking the help of the questions, plus we are dealing with the concept. So this is actual way how you will prefer for your exams. Read, revise, repeat of the concept. That is the theory based and the question based concept. This will be going to be helpful. Okay. So I hope it is very much clear to every one of you. And here it comes to the next question, and waiting for your excellent answer in the comment box. So please do engage your mind completely in the comment box and do mention the correct answer. Don't make gut, but take a 3 to 4 second extra. Do the correct answer. Yes, take a 2 to 3 seconds extra, not a problem. Do the correct answer. Yes. There is an 68-year-old post-menopausal woman is there. She is presenting to the having the complaints with a chronic back pain is there, and gradual loss of the height is there. Beta, we have heard that there is maybe a loss of the weight if we are not having the food, and here is the condition where we are seeing the loss of the height. Yes, so in a very few situation we will see that there is already increased height is reducing. That is only in a situation called as the osteoporosis. Getting the point? Very important. So height is reducing because the disc of the vertebral column is compromised, compressed, and the vertebral column is bending like this, where the height of the patient is reducing. A very important clue in the exams. There is a 68-year-old post-menopausal woman is there. She is presenting with a chronic back pain and the gradual loss of the height over the past 3 years. On examination, she is having the thoracic hypothesis. What is the hypothesis, beta? I told that we have the S-shaped, okay, minimally bended thoracic spine. Means the spinal vertebrae. If this particular thoracic region, if it is posteriorly protruded, or the posterior displacement, or there is a posterior bend or the outward bend of the thoracic spine, so that is called as the hypothesis. And I told you to remember L with the L, S with the S. Sir, what is the L with the L? That is the lordosis with the lumbar. That is the inward movement or the anterior bend of the our lumbar spines. We call that one is the lordosis. Lumbar lordosis, remember. Okay, and S with the S means there is whenever we will see the patient not by the lateral. So not by the lateral view. We are seeing the patient from the back. That time there is a side by side S shape there is in the curvature of the spine, that is we call as the scoliosis. And this particular hypothesis, that is the outward bend of the our thoracic spine. So where I have told in this particular image there is outward bend or the posterior push of this thoracic spine, where it is making the patient like this. So we call that one as the Dowger's hump. We call that one as the Dowger's hump. Okay, on examination, what we got here? We got a thoracic spine, so that is the thoracic hypothesis. And laboratory investigation is showing that is the normal serum calcium, normal phosphate, normal alkaline phosphate level. What may be the diagnosis of this particular condition? What may be the diagnosis? Tell me the answer. What may be the diagnosis? Yes, almost all you given the correct answer, because you have chosen the answer with there is the very important clue, that is in the loss of the height. So whenever there is in the loss of the height, so there is in the clarity of the answer goes towards the osteoporosis. But osteoporosis means it is a problem in the bone, not in the blood. So the serum calcium, serum phosphate, serum alkaline level, which may be a normal, completely normal in the blood, and there is a reduction of the calcium is from the bone. Okay, so that is the very important, you have to keep in your mind in the osteoporosis. Sir, what is the osteomalacia? So osteomalacia means this is the softening of the bone. So what is this one, sir? This is the softening of bone. Okay, so we have the very importantly two word here, that is due to the deficiency of the vitamin D. In the children we call it the rickets, and in adults we call it the osteomalacia. Deficiency of the vitamin D, no vitamin D, no calcium absorption, there is a soft bone. Okay, and remember, wherever the word malacia it will comes, it is the soft malacia, in the sense that is the soft, so that you can understand by the keratomalacia, there is a softening of the our conjunctiva. So we can say that one, sorry, sclera. So that is what we can call as the like keratomalacia. So that is the very important malacia, in the sense that is the softening, right? And we have the another condition, multiple myeloma. This is a cancerous condition of the plasma cells, the plasma cell cancer, which will damages the bone as well, because the plasma cell proliferation is happening through the our bone marrow, plus there is the increased bone destruction cells stimulation by the our multiple, means the plasma cells cells. Okay, very important. And we have the hyperparathyroidism. So this is also may cause the osteoporosis, but here there is in the hyperparathyroidism, the increased parathyroid hormone, means whenever we will check in the blood, so we will get the increased blood calcium, we will get in the hyperparathyroidism, increased blood calcium will be there. So in the given option, there is in the normal calcium, normal phosphate, normal alkaline phosphate. Getting the point, beta? Yes, sir. So this is the very important point you have to must and should keep in your mind. And here it comes to the a very important golden point revision on the osteoporosis, and the correct answer for the given question, which was there in the above. So that is our osteoporosis as the correct answer. Okay, yes, sir. So here it comes to the golden point revision on the osteoporosis. So this osteoporosis, one of the most common bone disorder. Okay, this is the one of the most common bone disorder, and this is we also called as the silent thief or the sneak up disease, because initially it will not show any kind of the symptoms. Okay, so initially this particular disease will not show any kind of the symptoms, and initially all the symptoms of this particular patient will be completely normal. Okay, so completely normal will be their patient, and it will be progress very slowly, and it will not manifest any of its symptoms until it will causes the fractures. Okay, so until it will cause the fractures, so or until it will compresses the our spinal cord. So that is the reason it is asymptomatic in the initial phase. Okay, not only initial few days, it will be asymptomatic until the bone will completely get weak. That is the reason it will silently destroying the bone. So we will call the silent thief disease or the sneak up disease. Very important. Okay, this one will be predominant in the elderly patient because of the aging process. That is what we call the senile osteoporosis. And this one will be predominant in the post-menopausal patient, because beta pre-menopausal means in the reproductive age of the woman, she is having the enough and very high amount of the estrogen that is protecting her bone. So in the post-menopausal, no estrogen, no protection, so there is in the bone resorption, and the patient may manifest with a back pain. And the classical thing you have to keep in your mind is the height is going to reduce. So height is going to reduce very importantly, because our spinal vertebrae are getting compressing, plus there is the bend of the our thoracic vertebrae, hyposis is happening. So because of this one, the height is going to reduce, very important. Next is the hyposis, we also call that as the Dowger's hump, where there is in the outward movement or the posterior movement of the thoracic vertebrae will be there. Okay, and whenever we will see the serum level of the calcium, that is the normal calcium, normal phosphate, and normal alkaline phosphate will be there in the osteoporosis. Okay, so osteoporosis is a silent disease until it is the fragility, until it makes the fractures. So that is the reason we call this the silent thief disease or the sneak off disease. Okay, very important. And vertebral compression fracture is the most common presentation we will get in the patient with the osteoporosis. Very important to be keep in our mind, and this is the golden points on the osteoporosis. Sorry, these are the very important golden points on the osteoporosis. Okay, and most importantly, you have to see that there is in the osteomalacia, and multiple myeloma, hyperparathyroidism, which was given in the options. Why these options are not correct? So I told Malaysia means softening. So here the bone is getting softening because of the deficiency of the vitamin D. So when the vitamin D is not there, means the serum calcium is low. Okay, so here the serum calcium was normal. Okay, and whenever the serum calcium is low, that time the alkaline phosphate will be increasing. So this is the very important. So in the given question, the alkaline phosphate is normal, calcium was normal, and the phosphate also was normal. Here there is in the low calcium and increased ALP is there, along with the vitamin D is because of the vitamin D deficiency. So that is the reason this is not a correct answer. And multiple myeloma, I told this is the plasma cell cancer, where it is primarily affecting the bone because the proliferation of the plasma cells happening from the bone marrow. And if someone is asking if the plasma cells will affect what are the very important things you can consider. So the plasma cells is mainly affects the very important, it will mainly affect the very important condition. So that is the bone and the skeletal system is the mainly affected in the our multiple myeloma, because the plasma cells will get proliferates from the bone marrow. Okay, and very importantly to be keep in our mind that there is in the anemia will also be associated because it is going to damage the bone marrow. So bone marrow is damaged, there is no any production of the RBCs and all. Okay, so there is in the high erythrocyte sedimentation rate will be there, and there is in the lysis will be there by the cancerous cells over the bone marrow. Okay, and there is in the hyperthyroidism, we have seen that the hyperthyroidism means high PTH means increased calcium in the blood. So here the hypercalcemia we will see, and the subperiosteal bone is getting resorption. Means what is the subperiosteal? So the outermost layer of the bone is the periosteum, and this below this one there is the bone will start to resorb, bone will start to weak, and bone will start to get damaged. So that is what we call the subperiosteal resorption we will see, and this will cause the osteoporosis. And in the given question, the calcium was normal in the blood. So here hypercalcium it is there in the hyperparathyroidism. This is not answer. And here we have the bone plus pain plus anemia, and here we may get the hypercalcemia also as well. And osteomalacia, here the increased ALP is there because of the low or the low calcium or the low vitamin D. So this is the very important thing to be keep in our mind. So these are the not correct answer of the above given question. Okay, here it comes to the next question, which is waiting for your brilliant answer in the comment box. So please do read the question carefully, correctly, and try to give the best answer. So I will be connecting you all within a 30 seconds. Stay connected, put the correct answer. I will be back. Okay, fine. Done. So there is a 65-year-old post-menopausal woman is there. So she presents with a low trauma of the vertebral compression fracture, and her DEXA scan is showing that the T score is minus 2.8, and serum calcium vitamin D level is the normal. So vitamin D is normal, serum calcium level is normal, and vertebral compression fracture is there, and the low trauma is there. And very importantly here the T score is showing that is the minus 2.8. So the question is, what is the drug of choice for initiating this particular treatment? So now the question is coming on the treatment of the osteoporosis. Better the T score is going the less than minus 2.5 means this is the very severe. This is the severe type of the osteoporosis. This is the severe osteoporosis. So I will tell you the interpretation of the T scores based on the DEXA scan, that is the dual energy X-ray absorptiometry. So that is also very important. That one we will see separately in the next very important question. Okay, in the next question only. So now we try to give the answer for this one. So first the question is very simple. Just the simple question is, what is the drug of choice for the initial management of this patient? So now I told you what is the patient. Patient is having the vertebral compression fracture. That's the most common presentation of the osteoporosis. And the drug like the investigation of choice, the gold standard investigation of the osteoporosis we have done is the DEXA scan we have done. In that one, T score is minus 2.8. I told the minus 2.8 means there is the severe osteoporosis. Just you have to tell me what is the drug of choice for the initial management of the this severe osteoporosis patient. Yes, option A, teriparatide. This is also we will use because this teriparatide will increase the osteoblast. And we have the calcitonin. This is also it will use because it will reduces the resorption of the bone calcium and it will maintain the bone calcium. Relaxifin also we will use in the postmenopausal woman. So because it will act as a selective estrogen receptor modulator and where it will increase the availability of the estrogen. And we have the alendronate as a very important drug of choice and initial drug of management as a bisphosphonates classification of the our drugs. So that is the alendronate. Alendronate, zoledronate, pomegranates are the drugs where we will use as the drug of choice in the osteoporosis. And from here, there is a question which will frequently arises from the nursing intervention while administering the bisphosphonates or the alendronates, because these alendronates or the bisphosphonates are having the one very important side effect, that is the esophagitis. Sir, what is the esophagitis? There is inflammation of the esophagus. Sir, what is the nursing intervention we have to do when doing the patient care of the alendronate? That is, remember beta, that is, we have to advise the patient to take a very important medication in the empty stomach and have the medication with a full glass of the water, and immediately after having the medication, don't sleep. At least be in a sitting position for 30 minutes or walk for the 30 minutes. This is the important nursing education we have to give to a patient who is taking the bisphosphonates or the alendronate drug. Getting the point? Yes. So this is the very important. And here it comes to the management of the our osteoporosis as a very important. Okay, so first line management of the osteoporosis are the classification of the drugs called as the bisphosphonates, and this bisphosphonates will have the drugs called as the alendronate, risendronate, and the zoledronate, pomegranates. So in this one, the most common clinically used drug is the alendronate. Okay, and what is the mechanism of this alendronate? So this is having the inhibition of the osteoclast mediated bone resorption, means osteoclasts are responsible for the resorbing the bone and deteriorating or degenerating the bone. So the degeneration will be inhibited because we are giving the bisphosphonates, that is the alendronate. It will inhibit the osteoclast. So there is less osteoclast, means there is no or the less bone damage. Okay, and it will increases the bone mineral density. Along with this one, it will reduces the vertebral and the hip fractures also. Very important. So that is the reason we will use this one as the drug of choice in the osteoporosis. And the very important nursing intervention you have to keep in your mind. This is having the most common side effect of the oral bisphosphonates is the esophagitis. So this esophagitis we have to prevent, means we must and should, patient must take the drugs on the empty stomach and full glass of the water to be used and remain upright position. So that is the sitting position at least for the duration of the 30 minutes or walk for the duration of the 30 minutes. It means don't sleep immediately after taking the medication. And we will give calcium plus, we will give the calcium okay, we will give the calcium plus vitamin D here. So because the calcium is responsible for the maintaining the mineral density of the bone, and vitamin D will be helpful for the absorption of the calcium. Okay, only giving the calcium is not helpful. Remember, always and always, if you are giving calcium along with that one, combine the vitamin D, it will increase the absorption and it will reach the circulation very nicely. And whenever you are giving the iron, that time always integrate with the vitamin C, so that will increase the absorption and it will makes its availability more. Okay, very important 2 points. And the next is we have the calcitonin. So we have the calcitonin, so that is the hormone responsible for the maintaining the bone calcium. So this one also we will give as a supplementation. And you have the relaxipin. So this one will be this is under the classification of the selective estrogen receptor modulator. So where we have already studied the drugs in the OBG, that is the selective estrogen receptor modulator. Okay, so here it is used in the postmenopausal woman, but it is not a drug of choice. In the postmenopausal woman also, drug of choice we have is the bisphosphonates only. So yes, we will use this relaxepine, okay, but not as a drug of choice, because this is having the side effect of the causing the postmenopausal symptoms. It will increase like a heart flushes. So that is the reason we will not use this one as the drug of choice. And we have the teriparatide. Okay, so we have what we have? So we have the teriparatide. So this one is used in the severe osteoporosis. This will increase the amount of the osteoblast, which will makes the bone. Okay, so I hope it is very much important and clear to every one of you. Is that clear, beta? Fatapat do thumbs up in the comment box. So is that concept is clear on the teriparatide, relaxofin, calcitonin, and the vitamin D plus calcium, and the very important nursing interventions and the drug of choice of the our osteoporosis, that is the alendronate, zoledronate, pomidronate, are the classification of the bisphosphonates. Is that clear? Yes, fatapat do thumbs up. Very nice of you all. Okay, so here it comes to the next question. That is the interpretation of the DEXA scan. So here you have the a very important investigation. This is directly tells us what is the bone mineral density is there, and it will very easily we can tell that this is the bone density of this particular bone, because this DEXA scan will measures the bone mineral density. Very important. So what is the DEXA scan? DEXA scan is a dual energy X-ray absorptiometry. That is the name of the investigation, where we are doing this one to check the how much density is there in the bone. Very important. And this DEXA scan interpretation will be done by using the T-score. Yes, so let me comes to the question. So here's the 58-year-old postmenopausal woman is there. She is undergone into the DEXA scan, and whenever we will see her report, so that lumbar spine T-score is showing that minus 1.8, and the femoral neck T-score is showing that there is the minus 1.5. So she has no history of the fracture. And how should the bone mineral density will be classified in this particular question? So now tell me, how should we classify the bone mineral density? Option A, normal bone density. Option B, osteopenia. Option C, osteoporosis. And option D, severe established osteoporosis. What may be the correct answer? What may be the correct answer? But if it is a normal bone density, it will never ever go less than minus 1. It will be always more than 1.0. Okay, so that is minus 1.0. Right? So if it is osteopenia, it will be belongs to the category of the 1 to minus 1 to 2.5. And if it is osteoporosis, that is less than 2.5. Okay, so you can see WHO T-score classification. First, it is must to memorize. Take a screenshot or write on a small papers and apply in front of your study table and send to my number also. So I will share that your chart in my channels also. Okay, so very important. Now here we have the WHO T scoring of the DEXA scan values. Okay, so normal in the sense which is more than or equal to minus 1.0, minus 1.0. And osteopenia means minus 1.0 to the minus 2.5. Osteoporosis means less than 2.5. If it is going behind the minus 2.5, so that is we can call it severe osteoporosis. Okay, so it is less than or equal to minus 2.5 plus fragility of the fracture, means that's the highest chance where simple push can break the bone of the patient. So that is what you can say as the severe osteoporosis. Getting the point? Yes. So this is the gold standard diagnosis we are using in the osteoporosis, and this is mainly used for the measuring the bone mineral density, and the DEXA scan full form is the very important for your exam. That is the dual energy X-ray absorptiometry. So I hope it is very much clear. And here in the given question, it is the minus 1.8 and minus 1.5, means where it is belonging between minus 1.0 to minus to minus 2.0. Right? So where it is belonging? Sorry, minus 2.5. So not 2.0. So that is minus 2.5. So it is belonging between this one. So it is belonging between this one means what is this classification? So this is the a classification of the osteopenia, not osteoporosis. If you want to say osteoporosis, it should be less than minus 2.5. Getting the point? Yes. So this is very important for your revision. And here it comes to the next question for your excellent answer. So please do read the question carefully, completely, and try to give the best answer. There is in the full term female newborn is there. That newborn is born in a breech presentation, and we are examined that on the day 2 of the life of that particular newborn, means the newborn is born and we have went for the round on the second day of the that newborn's life, and we are examining that particular newborn. On hip examination, means while examining the hip of that particular newborn, there is a clunk is felt when the hip is gently abducted and apply the anterior pressure. So we are just abducting the hip and apply the anterior pressure. That time we have heard the one sound called as the clunk or the click. Over where the greater trochanter we have applied the pressure. What does this finding indicates? What does this indicates? What does this indicates? Option is the positive Barlow sign. Option B is the positive Ortolani sign. Option C is the Galeazzi sign, and option D is the Trendelenburg sign. Okay, so Galeazzi sign we also call as the Ali sign. So that is one more clue I am giving. So now we have to choose the correct answer. Choose the correct answer. Yes. Ortolani sign, Barlow sign. Very nice. Okay, so this is the case of the Ortolani sign. So what it indicates? What it indicates? It indicates because there is the developmental dysplasia of the hip, means the hip is not developed properly. That may be a dislocation of the hip, that may be a subluxation of the hip, or there may be a dysplasia of the hip. So what these three words is mean? And in the Norcet exam, one time asked what is the meaning of the subluxation. Yes, let me clear the concept. Concept are the power and concept are the thing which will help us. Okay, so here these all four tests: Trendelenburg sign, Galeazzi sign, positive Ortolani test, and positive Barlow test we will discuss in detail in perfect. Plus we will discuss the developmental dysplasia of the hip, golden points. Stay connected, watch the complete procedure, and if any doubt you felt, so please do mention it without hesitation. Okay, so here it comes to the developmental dysplasia of the hip. So this particular developmental dysplasia of the hip, these cases will present to us in a three format. One, it may be a acetabular dysplasia, or it may be a hip subluxation, or it may be a hip dislocation. Okay, so what it means? Consider this better. This is the head of the femur, and this is the acetabular cavity of our hip. This is the cup-shaped acetabular cavity, and this is the head of the femur. Where the head of the femur normally should be like this in the acetabular cavity. Okay, so this is in the acetabular cavity. This will be the normal. If in case this particular acetabulum cavity is not developed properly, it is not in the cup shape. So this is called as the acetabular dysplasia, or abnormally or not properly developed acetabulum, or the acetabular dysplasia. And if it is developed but it is not completely cup shape, little is there, where the half of the head of our femur is inside and half is dislocated. Partially dislocated femur head is there. So this is called as the subluxation. If it is completely going, that is the dislocation. Yes, hip dislocation means from the acetabulum, our head of the femur is completely going out. That is the dislocation of the hip. And most importantly, half or the partial dislocation of the head of the femur, that is the subluxation. And there is not properly developed acetabulum only. This is what you call the acetabular dysplasia. Getting the point? Yes. So that is the very important, right? Come here. Acetabular dysplasia. It means underdeveloped or shallow acetabulum we have. So there is without complete loss of the joint contact. So there is in the No complete loss of the joint contact. The head of the femur is still in the contact. It remains inside the acetabulum only, but this acetabulum is not properly developed. So this is what we call as the acetabular dysplasia. We call this one as the acetabular dysplasia. Here the femoral head will be remain inside the acetabulum only. And we have the subluxation of the our hip joint. So subluxation means not completely. Complete luxation means completely gone. Subluxation means partially only. So partial displacement of the femur of the head, sorry, femoral head from the acetabulum means from the acetabulum not completely displaced, only partially displaced. So partially out but still in a contact with the acetabulum, that is the our subluxation of the hip. And here it comes to the dislocation. In the dislocation, what happens? Completely outside of the acetabulum. Complete displacement of the femoral head from the acetabulum. This is what we call the dislocation of the hip. We can see the image also. Here the our very important, we have the acetabular cavity of the hip. This is the cup shape and this is the head of the femur. Okay. So if it is completely out, so here is the our what we can say. We have the cup-like acetabular cavity, and here is the head of the femur, which is completely out. This is called as the hip dislocation. And here you can see, so this is our head of the femur, sorry, acetabular cavity, and this is the head of the femur. So it is not completely fitting also, and just it is partially dislocated in a contact, but partially dislocated. We call this one as subluxation. So I hope it is very much clear with the images furthermore. Okay. And normally it will be like this. Normally it will be like this. Okay. So here it comes to our acetabular cavity. And here it comes to our head of the femur. Okay. It should be normally like this. Getting the point? Yes, sir. The next very important points to be discussed here is, so that is related to the test we are doing in the developmental dysplasia of the hip, because these are the one of the prime and the very high yield test where in the every Norcet exam and in the alternative Norcet exam, especially RRB and any other state and central government exam, one question is fixed, striking repeatedly. Okay, so that is from the Barlow test and the Ortalani test, from the Alice sign, Gullis sign, and from the our Trendelenburg sign. So here we are discussing now about the Barlow test. The word the Barlow, you consider the B stands here is the Bura. Bura means bad. B stands here is the bad. So we are doing one bad thing here. So what we are doing, we are intentionally pushing the head of the our femur from the acetabular joint. Okay. So how we will push? So what we will do, we will hold the leg of the babies at the knee. We will adduct it and we will push a posterior pressure. So from here the head of the our femur is going out of the acetabulum. So you remember, Barlow means bad thing we are doing. That is adducting and pushing the posterior pressure. So the head will be head of the our femur will be get dislocated from the our acetabular cavity. This is the Barlow test. Okay. So Barlow test is attempt to dislocate the unstable hip is the Barlow test, where we are adducting and we are creating the posterior pressure. So where the positive means hip can be dislocated. Hip is going out of the acetabulum. That is the Barlow test. Barlow means Bura or the bad we are doing, you consider. Next is Orta. Ta. Tuck. Ta means you are getting the tuck sound here. T means you are getting the tuck sound here, or the click sound here you are getting, you consider. So what we are doing here? So in the last test, we have dislocated the head of the femur from the acetabulum. Here what we are doing? There we have adducted and posteriorly pushed. So we will abduct here and we will elevate anteriorly. So the head of the femur, which is gone out of the acetabulum, it is coming and setting immediately inside the acetabulum cavity. That time there is, we are hearing the sound called as the tuck or the cluck sound. That is the Ortalani test is positive. So this one is dissects the dislocated hip that is reducible. It is coming back to its original position. So in the first test, we have adducted, pushed and dislocated, and here we are abducted and anteriorly elevated. So where it is coming back. So when it will come back, that time we will hear the sound called as the tucks or the tuck or the click. Okay. So very important. Keep in our mind. And here we have the maneuvers, so that what we are doing is we are abducting and anteriorly lifting the hip. Okay, so there where the palpable clunk sound is getting, so that is femoral head comes back into the acetabulum, which indicates that there is the developmental dysplasia of the hip. Is getting the point? Yes. So here it comes to the next sign, that is the Gallagher sign or the Alice sign. So next sign is the Gallagher sign or the Alice sign. This one we will see when there is the unilateral developmental dysplasia of the hip. Means one side only there is in the hip dysplasia. So what I will do? I will make the child to get sleep in the supine position. I will flex the hip of the child and I will flex the knee of the child. And I will just look from the front side. So there is on the which side of the hip dysplasia is there. So that side knee height will be low as compared to the another side. This is unequal knee height when hips or knees are flexed. So because unequal, because this side of the acetabulum and head of the femur is fitting perfectly. Another side acetabulum is here and the our head of the femur is down. So because of this one, this side of the knee height is reduced. So this one will be seen in the unilateral developmental dysplasia of the hip. Which side height is reduced, that side of the leg is having the developmental dysplasia of the hip. Getting the point? Yes. So this Gallagher sign we also call as the Alice sign. We also call this one as the Alice sign. So this will be positive again in the developmental dysplasia of the hip. This is the one of the very important sign. So you have to keep in your mind. And here it comes to the Trendelenburg sign. So what we will do in the Trendelenburg sign? Simply we will ask the patient to stand and we will observe the pelvic. So that time when he will stand on the both leg, so that time pelvic means it will be equal. The right buttock, left buttock, pelvic folds will be completely equal. So we will ask the patient to stand on one leg. So he is having the two legs and he is standing on only one leg. So which leg he is rising above the ground or which leg he is not getting supported by the ground, that side hip will be going down, so that indicating that is a positive Trendelenburg sign. So you can see in this particular image. So here is the very important man we have here. Okay, so he is standing by showing the back here. So both foot are grounded. That time the hip is okay, stable, symmetrical. When he is lifting the foot and he is taking the support away from that particular lip, you can see this is the plane of the hip and one pocket is coming down and one pocket is still here. Means the one fold of the our buttock is coming down and one side fold will be remaining up. So this is what we call as the positive Trendelenburg sign. So positive Trendelenburg sign. Okay, so we will get the in a varicose vein we are having the positive Trendelenburg test. That is test. This is positive Trendelenburg sign. In the varicose vein we will study that there is the positive Trendelenburg test. Getting the point? Don't get confused. This is the positive Trendelenburg sign. Here the positive when the pelvis drops on the opposite side where on the standing leg. So which leg in this leg he is standing and opposite side the hip is coming back. Which leg is not supported, that side it is coming back. Ask the patient to stand on the leg. Observe the pelvis from the behind. If the pelvis drops on the lifted leg, which leg we have lifted from the ground, so that leg is pelvis is going down, so that indicates there is the positive Trendelenburg sign. Getting the point? So this is very important. So next comes to the where are the risk factors. So this is highest chance in the females and this is highest associated with the baby born with the breech presentation, which is given in our question also. You can see here. Okay, so baby born in a breech presentation. You can see a female newborn, one risk factor, female newborn, and who is born in the breech presentation, another risk factor. So both the risk factors are present here, and along with this one, so there is the very important developmental displacement of the hip. All the sign of the Ortolani cell is also positive here. Okay, yes sir. So this is very important. Next is we have that is management. So how we will manage? These are the image based questions which may strike here as very important. Okay, so please do remember here, if the age is less than 6 months, that time we will use the pH, power of the hydrogen, right? No, so that is the Paulic harshness we will use. So this pelvic harshness, what it will do, it will keeps the leg adducted and it will keep the head of the femur in the acetabular cavity only. So this is the work of the pelvic harshness, that is the flexion of the hip and adduction of the hip. Abduction of the hip. What it is doing, it is doing the flexion of the hip. You can see here it is the flexed and the adducted, means it is kept away, it is not near the body. What is the adduction, what is the abduction? You know ABD Villiers. ABD Villiers, ABD Villiers is the foreign country player that is away from India, means the body part which is going away, that is the abduction, and you are adding towards your body, that is the adduction. ADD add is the adduction, means the part is coming near to the center and from the center the part is going away, that is the abduction. So here we are maintaining the abduction and the flexion of the hip. So that is with the help of the pelvic harshness. This one will help us to keep the head of the femur in the acetabular cavity. Yeah, so very important point, and very important point you have to keep in mind. And if it is the baby or belongs to the 6 to 18 months, where we will use the closed reduction and hip spica. But we will use the two very important words. One is the CREF, and another one is the ORIF. So what it means? CREF means that is the closed reduction external fixation, means we will put the head of the femur back into the our acetabular cavity, that we have done closed reduction without taking any incision. So we are taking or we are cutting the skin and we are doing, means that is the open reduction, that is not a closed reduction. So how we are doing the closed reduction? By the rotating, by the manipulating, and by the bringing back into its normal body plane. So that is we are doing the closed reduction. So closed reduction means without taking the surgical incision, by the pulling and making the alignment, and we are fixing externally by using the spica. So that is the closed reduction external fixation, means not taking the surgical intervention, not put not inserted the wires, rods, like nothing we have inserted, pins, nothing we have inserted inside the body. Okay, just closed it, means we have pulled, made it align, and externally we have fixed it. That is the closed reduction external fixation we have. And another one is the open reduction external fixation, taking the surgical incision and holding the both end of the bones and making in a proper alignment, and putting the rod or the pin or the screws and making it tight, then closing the surgical intervention. What we have done? Openly we have done the reduction, and internally we have fixed with the pins, rods, and the screws. So that is the open reduction internal fixation. So getting the point? Yes. So this is the two very important word you have to keep in your mind in our skeletal system. So the 18-month-old boy is there. So that time what we will do? We will do open reduction and the osteotomy, and we will create the necessary surgical part, and we will make it properly. So that is the open reduction and osteotomy we have here in the more than 18 months old. Okay, so I hope it is very much clear. Here it comes to the next question, which is waiting for your brilliant answer, and this is one of the prime very important questions. But are the questions which will comes as a simple questions like vitamin A deficiency will causes what, night blindness, that one you will also make correct, your friend also will make correct, and their friend also will make correct, and who all are applied and appeared in the exam, everyone will make correct. But the rank will be decided on the questions which is challenging your mind, which is requiring the concept. So we are training with that one, we are dealing with that one, and you are getting the great knowledge in a free of cost. Please do utilize this one and apply in your exam. This will be very helpful for your exam. Okay, yes sir. So here what we have, here we have the 2-year-old child is there who is presented with a delayed walking. So one very important clue here is there is delay in the walking, means there is developmental delay is there. And we have the bowing of the leg as the classical clinical picture. The bowed leg, where we will get in the bowed leg, beta? Where we will get the bowed leg? Let it be, we will discuss this. Okay, and along with this one more clue we have, that is the frontal bossing is there. Frontal bossing is there. Are one more clue is there, we see in the question, that is the widening of the wrist. If one clue was enough, so the exam are given the three clues. Okay, so just you have to focus and choose the correct answer. That's it, your okay question. That's it, your work is here. Okay, so on examination there is a beaded appearance along the costochondral junction. So in the costo and chondral means, the chondral means the what you can say, the chondral part, that is the cartilage part, and the rib which is coming and connecting. So the cartilage part and the rib which is coming and connecting, in this part there is in the beaded like appearance, means that small round globules are there. So can I show the image to you? So you can see here, here you can see, getting. So here we have the cost is coming, so that is the our costal, means that is our ribs are coming, and here are the like ribs are coming, and this is our very important what we have as the cartilage. Here the costochondral junction is there, and here there is a beaded. Are you able to see this beaded, means elevated portion? So if you are palpating here, you will get the like round elevated portion. This is the beaded appearance of the costochondral junction, you can see. Okay, and I hope we have the one more image. Okay, same image we have. Okay, so that is the costochondral. You can, if it is not clearly getting, so you can Google it out. Okay, so this is one of the very important recently asked question in your medical PG entrance exams. So that is very important, you have to keep in your mind. Okay, yes sir. So in the beaded appearance is there in the costochondral junction, and which of the following is the clinical picture finding which is most characteristics of the rickets? So among the given all the options, which one is the clinical finding which is most characteristics of the rickets? Okay, so it is the most characteristics of the rickets, and almost 99% of you have given the correct answer, that is the rachitic rosary. But this is the clinical symptoms of the rachitic rosary, especially where there is a beaded appearance along the costochondral junction. So that is very importantly explaining about the rachitic rosary. So rachitic rosary means there is a deficiency of the vitamin D which is causing the rickets in the children's, and the deficiency of the vitamin D which is causing the osteomalacia in the adults. So here we are discussing about the deficiency of the vitamin in the children, that is the rickets. In the rickets we have the classical clinical finding, that is the rachitic rosary. So then when we will see the Bitrot spot, the Bitrot spot is the pathognomic clinical picture of the our vitamin A deficiency, where we will get the foamy white color triangular shaped structure over the our eyes. Okay, you can see here, this is the Bitrot spot. So this is a very important, and already 2 to 3 times asked question in the Norcet exams, and in state exams repeatedly asked question, that is the pathognomic clinical picture of the vitamin A deficiency, the Bitrot spot. Okay, and sir, what is the Kappa light spot? So because this Kappa light spot is the it looks like a copy with a milk like a mark over the bodies. So this one will be seen in the type 1 of the neurofibromatosis. So that is the neurofibromatosis type 1 disease condition. In this one we will see there is in the copy white milk like pigment on the skin. So that is what is called as the Kappa light spot. So you can see this one in the image. Okay, here you can see. So this one is the Kappa light spot. Are you getting here? That is the copy, like whenever we will add the milk in the copy, so that will be in this color. So that kind of the spot we are getting, or the mark we are getting on the skin. So this is seen in the type 1 neurofibromatosis. Okay, so neurofibromatosis. Okay, so very important. And we have Koplik spot as the pathognomic clinical picture of the measles. Okay, so I will show the image of that one also, and these all are important for your exams, so I have integrated at one time. So you can see here, so we have the Bitrot spot in the sense that is a foamy whitish triangular patch on the bulbar conjunctiva. This is due to the keratinization of the eyes, that is due to the deficiency of the vitamin A. So you can see a pathognomic clinical picture of the vitamin A deficiencies we have is the, that is the Bitrot spot. That is the Bitrot spot. And here it comes to the rachitic rosary. Rachitic rosary means this is the classical sign we will see in the rickets. That's the bead-like enlargement of the costochondral junction of the ribs. That is what we call the rachitic rosary. Okay, so you can see in the X-ray also. Okay, this is the image number A, which is having the image number A, that's the bitoid spot, and here we have the image number B. So that is the image number B, where you can see we have the ribs here. This is the sternum you consider out. Okay, this is the sternum you consider out, and here we have the chondro, that is the small cartilage which is allowing the ribs to come and collect. Okay, here we have the big cartilages. Okay, so you can see when our ribs will come in contact with a very important chondral area, so that is with the a cartilage area where the ribs, that is the costal is coming. Costal is coming and connecting to a rib area. This is called as the costochondral margin. So in this particular margin, there is in the globules like elongation is there. So that is what we call as the bead-like appearance, where you can see the bead like the small elevated. Okay, so that is the bead-like appearance. This is what we call the rachitic rosary, that indicating the classically indicating the our rickets. Okay, so next we have the coplic spot. So that is the a small bluish white spot on the buccal mucosa. Okay, so with the red base, this one will be classically seen in the measles, and the coplic spot on the rachitic rosary and the very importantly bitoid spot. These are the three very important markers where frequently asked in your exam. So as a very important points you have to keep in your mind. Okay, you can see here. So this is in the buccal mucosa, there is in the red base is there and the white. So here is the red base we have, and here we have the white spots. So red base is there, white spot. Red base is there, white bluish spot we have. So this is what we can call as the coplic spots that will be seen in the measles. Are very important to be keep in your mind. Okay, getting the point, beta? Yes, sir. So golden points about the rickets to be remember. The rickets is the deficiency of the vitamin D, so which is causing the defective mineralization of the growth plate, where the mainly and mostly it is affecting the bone and especially growth plate of the bone. And vitamin D deficiency, what it is, why it is happening? This is happening due to the inadequate sunlight exposure. This is happening due to the poor diet intake. This is happening due to the malabsorption, so due to the less absorption, and this is happening due to the chronic kidney disease. Okay, so CKD, that is the chronic kidney disease, is the response, means the normal kidney is responsible for the activation of the vitamin D. So where in the CKD, kidney damage, there is no activation of the vitamin D, so that may cause the demineralization of the bone. And the malabsorption, we are having the enough vitamin D, but that is not get absorbed by the our gut, so that is the malabsorption. Poor dietary intake, so the gut is ready to absorb, but we are not having the food that is rich in the vitamin D. And the inadequate sunlight exposure, so this is the very important, all the like contributory factor which is causing the deficiency of the vitamin D. Okay, when the vitamin D is get deficient in the children, that will cause the rickets, and it will get deficient in adults, that will cause the malacia, which malacia, osteomalacia. Okay, so that's the classical clinical pictures. Okay, that is the classical clinical pictures. Our high yield point you must and should know about the our rickets. One is the rachitic rosary, that is the beading of the ribs, as the very important. And whenever we will see the face, that the frontal bossing is there. You can say the boss, this boss frontal area is got bossed. Okay, so that is the very important. Remember, frontal bossing. And we have the craniotabs. So the craniotabs means the skull bones are very soft. Okay, so two words you will study, craniostenosis and craniotabs. Okay, so the craniotabs in the sense that is the soft skull bone, so very important point. Okay, and here we have the widened wrist and ankle. Ankles are also widened, wrist also widened, and here we have the clue to choose the correct answer, that is the bowing of the leg or the genu varum. Okay, so genu varum. So the two words you will study here, that is the genu varum and genu valgum. So genu varum and genu valgum. So what is the valgum? So valgum is the where the knees are coming together, and the varum is the knees are going away. So that is the bowed leg, means bended leg we have. You can see here we have the gap between the knee. So here we have the gap between the knee. So the knees are far away here. This is the what we can call as the genu varum, that is the bowed leg or the bowing of the leg or the like bow leg of the leg. So do you know this is the bow we have here? Okay, so we used to use in the Ramayana and Mahabharata for the wars. Okay, so the bow like bended leg we have, so this is what we call the genu varum. And genu valgum we have here, you can see the knees are came together and connected. Okay, so this is also called as the knock knee. This is also we call as the knock knee. So genu valgum we also called as the knock knee, and genu varum we also called as the a bowed leg. Sir, if it coming in the exam we will get confused about the varum and valgum, so please do say some crazy name or like trick to remember this one. So I hope every one of you will have the rum. Okay, so not now, after the Norcet exam clearing. Okay, so this is the rum bottle we have. Okay, I am taking this rum bottle, and this rum bottle I am placing here. So here we have the enough space to keep the rum bottle between the two knees, because the knees are wide apart. So I am keeping the rum bottle here, that is the rum we have. So this is the rum bottle I have placed here. So this is the rum bottle we have placed here, that is the we have the enough space for keeping the rum bottle, that is the genu varum, that is the bowing of the leg. Okay, and here we have the genu valgum, better we have the gum here. So what I will do, I will take a gum and I will attach between these two knees. Okay, so knees are attached means I have applied the gum here. Okay, so that is the gum means attached knees or the knock knees. Rum means that is the separated knees. Okay, so please to keep in your mind and don't get confused in the exams. This is how we will learn with the tricks, tips, and we will enjoy the sheets. Okay, yes. The next very important point is here it comes to the one of the very important sulcus, that's the Harrison sulcus will get on the chest. So that means there is in the horizontal groove will form, so that is just below the our costal margin or in between the costal margins. So that is in the horizontal groove. There is a horizontal groove or the depression is there along the lower part of the chest wall. So here this is called as the Harrison sulcus. This is also classically seen in the Rickets. And we have the one more very important thing here, that is the pigeon chest or the pectus carinatum. This is also classical picture of the Rickets, and from the Rickets you will definitely get the one question in the exam. So we have the genu varum, valgum, pectus carinatum, and the rachitic rosary and the Harrison sulcus. So lots of the clinicals, frontal boozing, lots of the clinical pictures which are classical. So one you will get definitely in your exam. Okay, so here we have the pectus carinatum. Carinatum means, so what happening here, we have the two words. One is pectus exacavitum, another one is pectus carinatum, where the sternum is coming out. So like how it is coming out, so I have attached one rope and I have attached this one to a car, and which is coming out, that is the I am pulling with the car, that is the carinatum. Carinatum means I am pulling with the car, where the a very important sternum is coming out, or the protrusion of the sternum out, that is what we call as the pectus carinatum. Okay, so we have the one more word, that is the exacavitum, means that time it will not come out, it will go inward. Okay, that is then the exacavitum means there is then the fear to the exam and going inside the room, that is the exacavitum. Remember, so the sternum is going inside, that is the exacavitum. Sternum is going outside, that is the carinatum. The exacavitum is the classical picture of the Marfan syndrome, not in the Rickets. Getting better? The sternum is moved inward, that is the very important exacavitum what I said, that is the classical picture of the Marfan syndrome. We will discuss the Marfan syndrome also. Okay, so pectus carinatum means the pigeon chest, like there is in the, like you can see chest of the pigeon, how it will looks like, that is the protruded. Okay, so that is the pigeon chest appearance or the pectus carinatum we have. So there is the anterior protrusion of the sternum we have. So this is, we can remember with the car is attached. Okay, so it is pulling your sternum, so that is the outward protrusion of the sternum is the carinatum or the pectus carinatum or the pigeon chest. And along with this one, there is in the delay and the dentation is there. Milestone will not be like attained easily, and hypotonia will be there in the Rickets. Okay, so remember, not a very important point, we have the pectus carinatum. We can see here. So there is in the chest is inward went. Okay, so chest went inward here. Okay, so this is called as the pectus exacavitum. So this pectus exacavitum, where we will get, so we will get this one. So you make this E bring it down and write the E like this. I will write the E like this. So that one we will get this one in the Marfan syndrome. This one we will get in the Marfan syndrome. So beta exa cavitum is a classical picture we will see in the Marfan syndrome, and the carinatum which we will see in the Rickets. Getting the point, beta? Yes, sir. So here you can see the very important table for you all. That is the pectus carinatum, means sternum protrudes outward, that is seen in the Rickets, and pectus exacavitum, sternum depressed inward, that is the congenital Marfan syndrome. Okay, yes, sir. So next it comes to the here. Read the question, the classical thing. Yes, read the question properly, perfectly, and do the best answer for this one. We will go with a discussion of the very important points again here, and this is one of the very important clinical questions where again you have the lots of the clues in the question, where there is the tall thin male is there, long fingers is there, and hyper extensible joint. You know, some people like this is the flexion and this is the extension maximum I can do, and some people this particular knee will go inside, okay, it will come out, that's the hyper extension. Okay, means I'm just giving the example, the knees will be like this, so that is the knees will go inside, and this elbow also like this, elbow will go inside, and this hand will come this back side. Okay, so this will be like this, that is the hyper extensible joint, and there is a decreased vision is there. On examination he has the pectus exacavitum. Okay, so that is I told a inward movement of the sternum and having the high arched palate. Okay, so the palate will be like it should be like a floor. If it is depressed and it is went inside like this, you can see in the image. Okay, so this is palate is went inside, this is what you call the high arched palate. Okay, so and ophthalmologic evaluation we have done, in that one there is on the upward displacement of the lens in its not in its original position. Okay, that is the lens ectopia is there, means lens went upward. Okay, so which of the following is the cardiovascular complication is most commonly associated with this condition? First you have to say which condition is this one, beta. So there are the classical clinical features we have, that is the hyperextensible joints, long fingers with a thin and tall old height man, and pectus exacavitum. Just now I am told that is the one clue. We have exacavitum, I have just brought it down. Okay, so like this here only we have done, that is in the Marfan syndrome. This is the baby of the Marfan syndrome, and these are the clinical features of the Marfan syndrome. There is in the 16-year-old, tall is there, thin is there, male is there, who is presenting with the long fingers and hyperextensible joints, decreased vision is there. On examination pectus exacavitum is there, chest is went inward, and high arched palate, the high palate is also went inward, and ophthalmologic evaluation showing there is the lens is displaced, so lens is went upward. Okay, and which of the following is the cardiac complication? Means you just have to say to me that what is the most dangerous cardiac complication where that may be a cause of the death in the Marfan syndrome. So these all clinical conditions are the clinical features which are telling that. So this is the case of the this is the condition of the Marfan syndrome, because these all are the clinical features which you will see in the Marfan syndrome only. Okay, yes sir. So in this Marfan syndrome, what is the most important cardiovascular complication associated? That is the beta aortic root dilation, which leading to dissection, so that is causing the death. Means simple we can say is the dissection of the aorta due to the aortic aneurysm, and most dangerously associated is the aortic aneurysm, and which is causing the dilation, and that is causing the dissection, means the damage of the aorta for the cause of the death, because the aorta is the main and the biggest artery which is supplying entire body of blood. So which is got damaged, means you know what may be the complication. Okay, so here it is mostly in the Marfan syndrome we have associated condition is the our abnormal dilation of the aorta, that is the aortic aneurysm plus rupture of the aorta. So that is the a very important thing, dissection of the aorta. Okay, so Marfan syndrome, please do remember This is the autosomal dominant disorder where there is no mutation of the fibrillin 1, that is the FB Facebook number 1 gene. Okay, so that is the, remember, Facebook number 1 gene, that is the mutation of the fibrillin number 1 gene. So just remember for the remembering purpose. Okay, so FBN1 gene or the Facebook number 1 gene or the fibrillin 1 gene. Just for your remembering purpose, I am telling the Facebook number 1. It is not a Facebook number 1 beta, it is the fibrillin 1. So don't say me that again, sir, the Facebook is not in the option. It is not, just for remembering. Okay, so fibrillin 1 gene. Okay, and we have the clinical features that there is in the tall stature is there with the long limbs, that is what you call the arachnodactyl, and we have the pectus exacavitum, so that is the chest is went inward. Scoliosis is there, so that is the side by side curvature of the our spinal cord or the vertebral column, and the upward lens is dislocated, that is what you call the ectopia lentis, means the lens is, means the eyes inside lenses went upward. Okay, and then there is in the hypermobile joint, what I told, there is in the hyper extension of the our elbows. Okay, yes, so that is the very important. Next we have the most dangerous complication is the root of the aorta is getting dilation. So when the arteries will abnormally get dilate or the aorta will have abnormally get dilate, what we can say, aneurysm. Okay, that is the aortic aneurysm will happens, and whenever this aneurysm will get ruptured, there is the aortic dissection will happen. This becomes the most common cause of the death in the Marfan syndrome. So please do keep in your mind, this is one of the high yield point for your exam. This is one of the high yield point for your exam, and try to understand the all the clinical features of the Marfan syndrome, and based on the clinical features try to identify the correct answer. So the examiner can give the like all these questions and he can ask you to what is the diagnosis, that is the Marfan syndrome. Okay, so please do keep in your mind, right? Yes sir. So here it comes to the next question. So please do read the question carefully, completely, and try to give the best answer, so which is best for your knowledge. Yes, important and very important MCQ. ಓದ್ಬೇಕು ದೋಸ್ತ, ಏನಿಲ್ಲ 1 ಗಂಟೆ 2 ಗಂಟೆ 3 ಗಂಟೆ ಒಟ್ಟು ವಿಚಾರ ಮಾಡಂಗಿಲ್ಲ. ಓದೋದಂದ್ರೆ ಓದೋದು, ಸೆಲೆಕ್ಷನ್ ಸಿಗುತ್ತಕ ಓದೋದು. ಸೆಲೆಕ್ಷನ್ ಆದ್ಮ್ಯಾಗ ಆರ್ಡರ್ ಕಾಪಿ ಡೌನ್ಲೋಡ್ ಮಾಡ್ಕೊಂಡ್ಮ್ಯಾಗ ಏಮ್ಸ್ ESIC ಮುಂದೆ ನಿಂತು ಒಂದು ಫೋಟೋ ಹೊಡೆದು ಆದ್ಮ್ಯಾಗ ರಿಲ್ಯಾಕ್ಸ್ ಆಗಿ ಓದೋದು ಬಿಡೋದು, ಅಲ್ಲಿ ತಕ ಓದೋದು. ಸೊ ಯು ಹ್ಯಾವ್ ಟು ಸ್ಟಡಿ ಅಂಟಿಲ್ ಯು ವಿಲ್ ಗೆಟ್ ದ ಜಾಯ್ನಿಂಗ್ ಲೆಟರ್. ದರ್ ಇಸ್ ನೋ ಎನಿ ಆಪ್ಷನ್ಸ್ ಯು ಹ್ಯಾವ್. It may be a 1.5 hour, it may be a 2 hour, it may be a 3 hour. Don't get relaxed. Relaxation is for the losers, not for the winners, not for the people who is running for the victories, not for the people who is there in the like line of the marathon. So just be relaxed by your mind and focus on the preparation. Everything is going to right, everything will comes to you on the right time. Just believe in you, believe in your blessings of the parents. Okay, so move on, that's it. Nothing will be going to lose. If you lose a real health, if you lose the real people's like your parents, then only something is will lose, otherwise nothing will get loose. Okay, so just don't think extra about anything. Be completely smart on your preparation. ಓದ್ಬೇಕಷ್ಟೇ, ಮತ್ತೇನಿಲ್ಲ. ಓದೋದು ಪ್ರಾಕ್ಟೀಸ್ ಮಾಡೋದು ನಾವೆಲ್ಲ ಹಂಗೆ ಬಂದಿದ್ದು ದೋಸ್ತಿಲಿ. ಗೆಟಿಂಗ್ ದ ಪಾಯಿಂಟ್? ಸೊ ದೇರ್ ಇಸ್ no any shortcut for the big things. So there are the small things, or you can go by the shortcut that will not give sufficiency also, that will not give comfort also, that will not give like a dream position also. Those things are having the shortcuts. So if you want to achieve something big, it will take a time, it will take a energy, it will take your entire energy, so that is required for that one, and then it will give the reward like you will not expect in your life. So that kind of the rewards you will get. Okay, getting in India, taking the 1 lakh rupees salary per month is not a joke. So that requires something extra energy from you. So you have to give that, you have to ready to give that particular extra thing. Okay, yes sir. So here is the question. A patient is a 24 hours post of the total hip replacement, means in the post operative period the patient is there. So that is the 24 hours have been done. And which of the following is the nursing intervention is the most important to prevent hip dislocation in an immediate post-operative period? Yes, a patient is 24 hours post total hip replacement surgery, means we have done the hip replacement surgery, now it's the 24 hours post-operative period. And which of the following is the nursing intervention which is most important to prevent the hip dislocation? Because the most common complication we will get after the hip replacement surgery is the dislocation. We will keep the head of the femur, there is the prosthesis in the a very important acetabular cavity. And whenever we will shift the patient, that time there is the most common complication is this particular prosthesis may go out of the acetabular cavity. This is the most common complication of the hip replacement surgery. So what is the most important preventive measure where it is preventing the dislocation in the immediate post-operative period? In the immediate post-operative period, we want to prevent the dislocation. Means what is the important thing to be done here? Option A, encourage the hip flexion beyond the 120 degree. No, beta. Maximum we can do up to 90 degree, not more than that. If you are bending the hip more than 90 degree, definitely the dislocation will happen. So option A is not going to be correct, because the maximum allowed will be up to 90 degree and less than 90 degree only, not bending allowed. Bending allowed, like bending more than 90 degrees not allowed. Okay, so place the pillow between the legs while turning. So you are turning the patient and you are moving the patient, you are shifting the patient. Remember, please do keep the abductor pillow between the two hip while moving the patient. That is the very important. While turning the patient, that is the very important. You must and should make sure that in between the two hip or in between the two legs, there should be a pillow. This is the very important nursing intervention which will prevent the dislocation of the hip. Definitely it will help to prevent the dislocation of the hip, because if we are keeping the hip abducted and slightly externally rotated, that is the very important measures we have to follow after the total hip replacement surgery. Very important. That is abduction of the hip and just lightly external rotation, and completely avoid the internal rotation of the hip. If the hip is internally rotated, consider the hip is displaced. Hip is displaced. Or the sudden height of the foot is reducing, you consider the hip is, means hip joint is displaced, or there is a dislocation happen. So very important. Internally rotated hip, just short length of the leg, so that indicates the hip dislocation has happened. Okay, so option C is allow the patient to cross the leg while sitting. I told beta, if you want to cross the leg means you have to adduct the legs. So adduction of the leg is not allowed. Keep the leg abducted, that is away, like this. I will show the image. You can see the image here. So do we have image here? No, image is not there. I will draw for you, don't worry. Just a simple, I can draw the things. Okay, so just you can remember this is the two legs. Okay, in between these two legs here we have to keep the pillow. Definitely we have to keep the pillow here. So this is a very important thing you have to must and should keep in our mind. Okay, this is how we have to keep the pillow. This is very important. Okay, yes sir. So here this is the very important. Next is the option C we have is the allow the patient to cross the leg. Now if the patient is crossing the leg, definitely the hip will get dislocated, and keep the patient high polar position. Now high polar position, what happening here? So there may be a over bending may happens, because the hip will get flexed in the high polar position. Okay, and encourage the patient internal rotation of the operated leg. If the internal rotation have been done means, so if the leg is internally rotated, that indicates the definitely the hip will get displaced. So I told how we have to keep this one: abducted separately and slightly externally rotated. That is the ideal position where we have to keep. Okay, yes sir. So this is, I hope, very much clear, and the correct answer for this one is the option B. And I am going to teach you the rapid revision point where what to do and what not to do after the hip replacement surgery. So the most common complication of the total hip replacement is there is the dislocation of the hip, and the prevention of this one will be the your responsibility as an AIMS nursing officer, as a ESIC, JIPMER, and whatever the institute you want to join. So that central government nursing officer, it is your responsibility to prevent the dislocation of the hip, because surgeon have done it, suturing everything you have done, and you have placed it, and now you have to just maintain, that is you should not allow it to get dislocated. Okay, so most important nursing action will be maintain the abduction with the pillow. Okay, so maintain the abduction with the pillow. So just we have to separate the leg, and in between the keep in between that we have to keep the abduction pillow with just slight external rotation. Okay, so with just slight external rotation, not complete external rotation also, and never ever allow the internal rotation. Important post-operative precautions. What to do? So do's. What to do? Keep the pillow between the legs while lying or while turning the patient, while sitting the patient, and maintain the hip abduction and not allowed to get adduct and not allowed to get cross the leg. And use the raised toilet seat. And remember that beta, every time where the patient is sitting, that time hip should be higher than the knee. Okay, it should not like here is the patient you consider. This is the toilet seat, you consider that. Okay, and here the patient is sitting, and this is the hip of the patient. Knee should be always lower than the hip. Means this is the hip means this is the hip means this is the knee, and knee should be always lower than the hip. Knee should not ever, because if the knee is going more than the hip, means here the more than 90-degree bend has happened. More than 90-degree bend is happening means the dislocation will happen. That is the reason while using the toilet seat, use the heighted toilet seat or the raised toilet seat only. That is the very important point. Okay, yes sir. So use the raised toilet seat and sit on the firm and high chairs only. So always knees always should be lower than the hips. Knees should not never ever higher than the hip. So this is the golden point. And keep the hip flexion less than 90-degree, and it should not go more than 90-degree. If the hip is flexing more than 90-degree, there is highest chance of the dislocation. And sleep on the back or the non-operated side with the pillow supported in between the two legs, and never ever keep the patient on the operated side. If you are keeping the patient on the operated side, it will dislocate the hip. And perform the prescribed physiotherapy as a very important. Take the medication regularly, especially anticoagulants and the pain medications, because we are keeping the patient immobilized here. So the risk of the DVT will be there, the anticoagulants to be given here. Okay. So, and very importantly, we have a complication at the surgical site we have to monitor. So that is the severe pain and the swelling, redness, and the fever. So this indicates that there may be in the complication. Okay, especially severe pain and the fever, which may indicate the surgical site infection. Sudden shortening of the leg, which indicates the dislocation. This indicates the dislocation of the head of the femur from the hip, and swelling, redness in the calf, which indicates there is the DVT because of the prolonged immobilization. Getting the point? So these are the signs of the complication we have to report immediately to the doctor. Okay, so next we have the don'ts. We should not do. What are the things we should not do? Don't cross leg, don't adduct the legs. Okay, so do not cross leg, do not bend forward excessively, and do not sit on the low chairs or the low sofas, because you know some sofas it will look like a heighted. Whenever you will sit, it will suddenly will go inside. Okay, so that time the hip may flex more than 90-degree. The knees may come more than the height of our hip. So that one we don't want. Okay, so do not sit on the low chairs and do not sit on the sofas. Okay, and do not twist your operated leg inward. Never ever internally rotate. Avoid the internal rotation. If internally rotated, the hip is dislocated, you consider. Okay, so do not turn the twice inward. That is, the internal rotation should be avoided. And do not flex beyond the 90 degrees. Up to 90-degree allowed, more than 90-degree you should not bend it. And do not sleep on the operated side, because the operated side you are sleeping means that will create the pressure dislocation will happen. So, okay, do not lift the heavy objects, and do not engage in the high impact activities like running and the jumping. So these all things should be avoided. Okay, very important. Next comes to the next very important question for your brilliant mind. So please do choose the correct answer and read the question completely carefully, and to do the to choose the correct answer. Okay, here's the patient with a femoral fracture is there. Femur bone is got fracture, and on the skeletal traction patient is there. And which of the following nursing intervention is most appropriate to maintain the effective traction? So to maintain the effective traction, which of the following nursing intervention is most appropriate to maintain the effective traction? Yes. So what is the correct answer? Choose the correct answer, put it in the comment box. Yes, don't overload yourself. So relax, cool, composed. That will increase the effective work. If you are hurrying means you can cover the things very fast, but that is not enough. That is not that much effective. Go slowly, perfectly. That is going to be a marks decider. That is the very important point I am telling. That is telling with the experience. If you are hurrying means you can cover the entire syllabus, but the output will be not what you are expecting. So go slow, perfectly understand the things and move on. And don't run behind the unnecessary things. Only you have to revise the necessary things. Okay. So as it will comes in the exam, that things only you have to focusly revise. Okay. Yes, the high yield topic list already have provided. Very important list. Okay, so in every one topic what I have given, that may be a there may be a chance of striking the two or three questions from the one topic. Those like all the topics we have listed and we have covered. If you have already done that one by the A1 course, no need to watch the videos again. Just revise the notes. If you have not done so, please do play that one in a 1.5 to 1.8 speed and cover it at least. Okay, very important point. And notes also provided for you, so don't go like don't any take a heavy notes. So you are writing 10 phase 20 phase, that is not going to useful now. So just watch the video, take a golden point notes, and the immediately revise the entire PDF notes immediately after the class. That is very much helpful for you all. Okay, so that one is the how we have to quickly revise. Through the crash course also we have given the list, and the even plan also you have given the list. Okay, so yes, there is a very important question. Come back to the question. A patient with a femoral fracture is there on the skeletal traction. So patient is on the skeletal traction. Which of the following is the nursing intervention? So that is the most appropriate for the maintaining the effective traction. So one very important main goal is for the traction, that is the uninterrupted pulling force we have to maintain. Okay. Yes, pulling force is very important, but uninterrupted means there should not be any gap in the pulling force. So that is what we call the uninterrupted. It means pulling force should be continuous without any gap. Very important. If you are removing the weight, if you are lifting it, means you are keeping the traction on the ground, that is reducing the weight, that time the purpose will be destroyed. So what is the purpose of the traction? In order to maintain the alignment of the bone. Okay, it is pulling and maintain the alignment. And along with this one, there may be a purpose of the reducing the muscular spasm. So the muscular spasm again it is causing the misalignment. So that one we don't want. In order to keep the bone at alignment, so we have to continuously maintain the pressure. That is the pulling force. That is what we call the traction. Traction is the pulling force which we are continuously or uninterruptedly maintaining in order to keep the bone in the aligned way, and we in order to keep the muscles in a relaxed condition, so that should not be get spasm. Okay, so what is the most appropriate effective is the effective way to prevent this particular in order to maintain the continuous best traction. So what is the most appropriate nursing intervention is the question. Option is telling that remove the weight temporarily during repositioning. If you are removing the weight temporarily, that will cause the interruption. I told the uninterrupted, it should be the pulling force should be the uninterrupted. Okay, if you should not remove the weight until the doctor will tell that, until there is an emergency situations. Never ever remove the weight. Okay, so very important. And allow the weight to rest on the floor. Better. So we have kept the traction. So this is a consider a patient, and this is the leg of the patient, and from here there is a traction is there. Okay, so the traction means there is a pulling force is there. So here's the weight is there. So if this particular weight is resting on the floor, means is this will pull the our body part? No, it will not pull the body part. Never ever the weight should never ever rest on the floor. Better. This is the very important. Weight should never ever rest on the floor, and you should not keep any pillow, any like nothing to be kept below this weight. Very important. And you should not keep anything on this particular pulley. Okay, so here we have the pulley. So from there the rope is moving on. So on this one you should not keep towel and all. Nothing should be given. Like keep here, because we have to frequently observe that one, and it should not be get covered. And option C is that ensure the weight hang freely at all time. This is the very important. If it is hanging freely at all time, that will maintain the uninterrupted pulling force. And loosen the ropes if the patient reports discomfort. This is also not to be a correct answer. So yes, there may be a minor discomfort, normally will be there until it is a severe emergency. So you should not remove the weight. If it is an emergency, you can remove. Okay, until that one, there is no any indication of the removal of the weight from the our pulling force. Okay, so that is very important. And here we have to make sure that in order to maintain the effective traction, we ensure that the weight should hang freely at all time. And here it comes to the a very important points to be remembered and points to be revised from the pulling force and the nursing intervention in the patient with the traction. So that the traction is the continuous force. It must be never be interrupted. It is a continuously maintained. Means never remove the weight, never keep the weight on the floor, never keep anything below the weight. Okay. So traction is interrupted means there may be a muscle spasm and the misalignment of the bone may happen. So that we don't want. And the traction is used to maintain the alignment and reduce the muscle spasm and immobilize the fractured area. This is the main purpose of the traction. If you are removing the weight unnecessarily and if you are like while turning, while shifting, you are removing the weight, means that is no use of the applying the traction only. Okay, very important. What the nurse should do here. Okay, so as the priority assessment, perform the neurovascular assessment as the priority assessment once after installing the traction. So distal part of the traction we have to check for the pain, pallor, pulselessness and the paresthesia and paralysis. If anything of this one will be there, so that one we have to immediately inform to the primary health care provider. Okay, so if anything of this problem is there, so immediately inform to the primary health care provider. Other than this one, ensure the weight should be hanging freely. Okay, so weight should not be placed on the ground and it should not be kept below the weight, and maintain the body alignment properly and check for the rope. It is like rope should be means the thing, that is what we can say, the pulley will be there. Okay, so on this pulley the rope should be freely moving like this. Okay, it should not be any knot here. Okay, there should not be any knot on this particular rope where it should be like a hamper with the pulley. It should not get happen like this. Okay, and provide the skin care. So this is also very important. And this is the very important points you have to keep in mind. Along with this one, so if the patient is on the skeletal traction, the priority nursing intervention is the provide the pin side care, because the patient inserted the pin, so that is inside the bone and the pin is externally we have. Okay, so you know this is the knee you consider, and here we have the leg. Okay, and here we have the bone, and the pin is inserted like this. So it is inserted this end of the skin, entered inside the bone, and which is coming out of this end of the skin, and through this one we are applying the weight, that is the skeletal traction, what we can say, because we have inserted the pin in the bone and the pulling force is applied to the bone directly. So here you can see this is the site where the pin went inside. And if we are not taking care of this pin side properly, this pin side care is not done properly, means the bacteria will go through this particular pin directly into the bone. So the osteomyelitis risk will be high, very high. So that is the reason, if the patient is on the skeletal traction, the pin care is the very important to keep it clean, dry, and very importantly should not get wet and the infection. So that is the very important. And regularly we have to clean this particular area, both the side. Okay, so I hope it is very much clear to everyone. Right? So this is our 3-star point. So where it may strikes in your exam, pin side care. And what should the nurse should not do here? So that is, never ever remove or lift the weight. Do not let the weight to touch the floor. Do not adjust the traction without medical order. Do not place the object on the ropes, should not be kept on the rope, and do not allow the knot to touch the pulley. Okay, so the knot should not touch the pulley. What I told here. So this is the pulley we have, and this pulley, this particular knot should not get stuck here, because that will reduce the traction power. Okay, yes sir. So these are the do's and not to do's. Okay, so you have to make sure that. And here it comes to the next question. Okay, read the question carefully, completely, and try to give the best answer. Yes. A patient is there who is recently had a plaster cast which is applied for the tibia fracture. So for which fracture there is in the tibia fracture is there. Okay, and for this particular fracture there is in the plaster cast which is applied. Okay, and now patient is complaining that difficulty in the lifting the front part of the foot or the dorsum of the foot. Beta, consider this is my leg and this is the my foot. Okay, and this is the dorsal portion of the foot. The front one is the dorsal portion, and this is the white one. What we have is the this is the plantar area of the foot. So this is the dorsum of the foot. This is the plantar area of the foot. Okay, so now what the patient is telling? He is telling difficulty in the lifting of the dorsum means, so the foot is, it should be like this. Okay, so he is having the difficulty in the lifting of this particular dorsum means the foot is now like this, means the toes of the foot is like hanging like this. Okay, it is like touching to the floor while walking. Getting the point? So patient is having the difficulty in the lifting the foot like this. The dorsal flexion is not happening. Okay, so this is we also call it the foot drop. What we call this one is the foot drop. Okay, so there is a difficulty in the lifting of the dorsum part of the foot or the front part of the foot. So this is we also call as the foot drop. Now the patient is complaining of the signs symptoms of the foot drop. Okay, so while walking on examination, foot hangs down and the patient drags the twice. Okay, so while walking, what happening? That he is not able to lift it properly means he is dragging the twice like while walking. So when he will move, so that it is he is not lifting means, so he is unable to lift means that twice will be dragging to the ground only like this. Okay, and injury to which of the following nerve is most likely the cause of this one? Very important. The simple question is, foot drops happens due to the which nerve injury? That's the very important question. But there are the two very important concepts I want to teach you here is, one is nerve responsible for the plantar flexion, nerve responsible for the dorsal flexion. So you are asking the patient and he is making the flexion of the foot like this, the dorsal flexion he is making. For this one, the nerve responsible is, okay, so this is the foot and you are asking for dorsal flexion and he is flexing that one. For this purpose, the nerve responsible is the deep perineal nerve and the superficial perineal nerve. Main one is the deep perineal nerve. And you are asking the patient to move the twice like this, and he is moving like this towards the plantar and he is doing the plantar flexion. So for this one, the main nerve responsible is the tibial nerve. So the patient is unable to do the plantar flexion, the tibial nerve is damaged, and the patient is unable to lift the foot, or unable to do the dorsal flexion. The deep perineal nerve is injured, and in the foot drop, the most common nerve injury will be the deep perineal nerve. So that one is not there in the option. So what may be the correct answer? Yes, there is the common perineal nerve, which including the both superficial and the deep perineal nerve. So the first priority answer goes to the deep perineal. If it is not there in the option, you can choose for the our common perineal nerve. Okay, so you have to choose for the common perineal nerve. Very important. And you remember that there is a dorsiflexion, means the patient is lifting the foot and there is a dorsiflexion is there. So there is the lifting of the foot upward, okay, which indicates that common perineal nerve is functioning, and there is a word we call as the plantar flexion, means the pointing the twice downward like this. So this is indicating that the tibial nerve is functioning. So what is the foot drop? Foot drop is inability to do the dorsiflexion of the foot. Okay, he is unable to lift the foot. That is the foot drop. So the twice drags while walking. While walking, he is unable to lift the foot, means he will lift the entire leg, and there is the high stepped gait will be there. Okay, so to walk from here to here, this much lifting of the foot is enough. While the dorsiflexion is there, so this much lifting of the foot is enough. So now, due to the dorsiflexion is not happening, the twice are dragging on the floor. He will keep the step like this. He will lift and he will keep. That is the high stepping gait will be there. Okay, high stepping gait will be seen in the foot drop. Okay, so there is a stepping gait or the steppage gait we have. So this will happen due to the compression or injury to the common perineal nerve is the very important thing. And if the first priority answer will be the deep perineal nerve, this is the first answer. If this one is not there in the option, so we can choose as the common perineal nerve as the very important second option. Getting the point? But yes, sir. Next we have is the foot drops, how we have to prevent that one. So just we have to maintain the foot at the 90 degree when the patient is prolonged time immobile. So the foot will be dragged like this on the bed. So that one we should be avoid, and we will keep the footboard at the end of the foot, and we will maintain the ankle at the 90 degree where there is no any compression on the peroneal nerve. No compression on the peroneal nerve means no any foot drops will happen. Okay. So foot drops to be prevented by maintaining the ankle at the 90 degree in a position, and the best device we are using is the footboard we are using. So footboard we are using. Very important. Footboard is used for the foot drop as a very important point you have to keep in your mind. And image based question also, the IBQ also you can keep in your mind. Okay. So next we have the ankle foot arthrosis. That's the AFO we have. So this one is used again for the prevention of the foot drop. Okay. So because the patient is having the highest upper gait, and most importantly, what the patient is having? The patient is having the dragging of the twice while walking, that the twice will be get damaged. So that in order to avoid that one, we will use the ankle foot arthrosis, where it will be maintaining the 90 degree flexion, and the patient can be walk by lifting the small leg only. It means the little height only he can lift and walk, so without a problem. Okay, so there is no any height stopped gait also will be there. There is no any dragging of the foot will be there if you are using the ankle foot arthrosis. Getting the point, beta? Yes, sir. So these are the very important points you have to keep in your mind. And here it comes to the next very important question. Yes. A patient is 48 hours post below knee amputation have been done. So means below the knee amputation we have done, and it is already 48 hours have been passed. So which of the following intervention is most important to prevent the hip flexion contraction? So what is the most important to prevent the hip flexion contractions? So what happens? Understand here, dear students, what is the amputation? Amputation is any diseased extremity which we are unable to treat by the medication, which we are unable to recover it by the surgery. That time what we will do, we will cut that particular point and we will remove that particular point. That is what we call as the amputation. So amputation may be done to the upper extremities and to the lower extremities also. In the upper extremities, not usually done, and in the lower extremities, usually it will be done. And in the lower extremities, if it is doing below the knee, we call that one as the below knee amputation. So that is the BKA, below knee amputation. And if is the cut of the extremities foot we have done above the knee, that is what we call the AKI, that is the above the knee amputation, AKA. Getting the point? So these are the based on the location of the cutting line, removing the body part, we have the amputation. Here we have done the below the knee amputation, means just below the knee we have removed the body part. That is the below the knee amputation we have done. Most important to prevent the hip flexion here, contraction, what we have to do. So what is the contraction is the most common complication of the amputation. Okay, so we have removed the leg, and we have the particular body part which we have removed is that is the amputated part, and which is remaining is still in a contact. This is complete leg you consider. Okay, this much I have removed, so this is I will discard in the yellow bin, and this one remaining what I call as the stump part I will call. Okay, so here in the stump part I will pull the skin and I will make a suture here. Okay, so skin pulling I have done, and I have keep this one in this particular flexed position for 3 days you consider. So after 3 days I want to lift it, I am unable to lift because the skin I have pulled and the sutured here. So I am trying to lift, means the skin become again tight and I am unable to lift. So the contractions will form here. So that contractions I want to prevent, means I want to keep the patient in a prone position and in a stable straight position. So where it should not be get flexed, extended, and it should not be like body should not be over flexed, over extended. It should be in a straight position. So healing will happen and the body remains in a straight position after recovery also. Otherwise the contraction is happening, means that is the very dangerous thing. Okay, so the most important thing here is to prevent the hip flexion contraction is which one? Option A, elevate the residual limb on the pillow continuously. Beta, in the fundamental of the nursing Potter Perry book, clearly written that do not elevate the residual limb on the pillow. Sir, if prescribed by the doctor to control the bleeding, what we have to do? We have to raise the foot end of the blood, and again the body alignment will be in a straight foot end of the bed we will rise. Do not raise the amputated leg on the pillow. That is the wrong practice. It is clearly written in the Potter Perry book. You can go and check out. Okay, so very important. Elevate the residual limb on the pillow is not recommended if the doctor is advised in the initial period in the first 24 hours in order to reduce the edema and bleeding, in order to reduce. So if the doctor wants to elevate, so elevate the foot end of the bed, not on the pillow. Getting the point? Yes, sir. Next is, because the reducing, like raising the part on the pillow increases the contractions at the knee and contractions at the hip. Okay, place the patient in a prone position several times in a day. So here it is, the patient is in the post 48 hours after the amputation. So we can keep the patient on the prone position, because all our joint of the body will remain straight, so that the hip will be straight, knee will be straight. Okay, so when we will keep the patient in a prone position, so this position we will maintain at least several times in a daily routine. So this is very important. This will prevent the contractions. Very important. This should be done by the nursing office. This is the most important intervention to prevent the especially hip flexion contractions. And keep the stump flexed while in the bed? No. Should not be kept flexed and should not be kept extended. It should be in a straight position. And avoid turning the patient. We have to frequently turn the patient, because in a single position we are keeping for the prolonged time means that will produce a contraction that we don't want. And the avoiding turning will be a like wrong option here. Okay, I am eliminating the option D. Okay, so I am eliminating the option D. I am eliminating the option C also, and I am eliminating the option A also, and option E is telling keep the head of the bed elevated all the all time. No, this is not recommended. If you are keeping the head of the bed elevated, again the contraction will form at the hip, because hip will flex here. So that one we don't want. Okay, so that I will not keep the head of the bed elevated at the all time. So if required, I will keep the foot end of the bed high, so that is helpful for me. And the most importantly, I will keep the patient in the prone position. Okay, so this is to reduce the contraction after the amputation. Okay, so most common complication is the contracture. Most important intervention is the prevent the hip and knee contracture after the amputation. Prone position is the key intervention to reduce the amputation, contracture at the hip and contracture at the knee. Both will be prevented by the maintaining the prone position. And the question is coming, after the amputation, what is the ideal position as a nursing officer you have to keep the patient is, that is the prone position. Okay, and what are the things we have to do after the amputation? So that is monitor for the bleeding and infection at the site of the amputation, and perform the proper stump care, means remained part of with the body, so that is the stump care, and apply the compression bandage to control the bleeding, encourage the range of the motion exercises, promote the early mobilization. The mobilization will prevent the contractures, provide the psychological support, because we have removed one active body part. So yesterday he was running, he was walking, he was like involving in the functions with that particular leg, and today we have removed that particular leg. You consider how the emotionally or psychologically damaged he is. So we have to provide the psychological support as well. And the phantom limb pain, very important. So this is very important. What is the phantom limb pain, beta? Phantom limb pain, you consider that here we have the body, and here is the foot we have. Okay, so here is the foot you consider we have, and this was the foot. This much was the foot which was involved in the disease condition, where it was causing the pain previously, regularly, continuously, painful, irritation. Okay, so since from the 4 year, 5 year, continuously pain, irritation is there. So today I have taken the patient to the OT, and I have removed this particular part which is involved in the pain and irritation. So still patient will feel the pain here even after removing that particular body part. He will tell that my foot is still is there and I am getting the pain there. That is what we call the ghost pain or the phantom limb pain. That is what we call that as the ghost pain or the phantom limb pain, as a very important point you have to keep in your mind. Okay, so this one we have to manage with the mirror therapy, and we have to like repeatedly reassure the patient that this is the a part we have already removed and we have to manage this one as the mirror therapy. Okay, so mirror therapy and the phantom limb pain, already have ghost pain already discussed in the psychiatry. So please do open the notebook and revise that one, so that will be helpful. Okay, so here it comes to the next very important nursing intervention. When the above the knee amputation is done, means amputation means the part we have removed from the above the knee. You consider this is the full length of the leg we have. Okay, and here it comes the foot and here it comes to the knee. So we are removing the body part from here. Okay, so this much body part we are removing. So this is above the knee amputation. Okay, if in case so we are removing the body part from here, so this is what we call the below the knee amputation. Okay, so what are the interventions as specifically we have to follow in the above the knee amputation? So there is the highest risk of the hip flexion in the above the knee amputation, because so there is knee is not there, means knee contraction or the knee contraction formation is not there, because knee we have removed already, and the where the contraction can form, so this skin may get tight here and which may form the contraction with the rest of the body, that is with the hip. Okay, hip contraction may happen here, very important. Getting the point? So here in the above the knee amputation, high risk of the hip flexion and external rotation contracture is there. So the very important nursing intervention is after the knee amputation, never ever allow the body part to get externally rotate here. So this is a very important thing you have to follow here. So in order to prevent the hip flexion and knee external rotation, what we have to do? So externally means by side we will keep the sandbag, place the sandbag laterally to prevent the external rotation, and to prevent the hip flexion, encourage the patient to be in a prone position. Give the prone position, keep the sandbag lateral part of the foot, where the lateral part means the foot will not externally rotate. So because there is a high risk of the hip flexion and external rotation contracture is there, so this one we don't want, that is the reason. So we will maintain the encourage for the prone position, and very importantly place the sandbag laterally to prevent the external rotation is the very important. Then avoid the prolonged hip flexion to be avoided here. Getting the point? Remember. And here we have the below the knee amputation, means we have removed the leg from here, we have the knee and we have the hip. So here there is the risk will be there for the both, but the most important risk will be there for the knee. So because the knee flexion contraction is happened here. Okay, so here the nursing actions comes, avoid the prolonged sitting, especially sitting with, you consider this is the bed and this is how patient is sitting and knee is like remaining stump is freely hanging. This one should be avoided. Okay, so because freely hanging means it is flexing here, means it is healing in this direction only, after that patient unable to extend this one. So that is the very important you have to keep in your mind. Okay, so do not allow the stump to hang down for the long period, and encourage to knee extension exercises we have to encourage. Do not elevate the stump. Okay, so do not keep the stump elevated on the pillow for the long term, because it will cause the flexion contractions. So then what we have to do, if a physician have ordered elevation, so elevate the foot end of the bed, not the stump directly. So only stump you should not elevate on the pillow, you have to elevate enter the foot end of the bed, so that will prevent the flexion contraction. So this is very important points you have to understand here. Here it comes to the a very important next question. So that is the, here the patient is complaining of the pain and swelling is there near the calf muscle. Where is the pain and swelling? So pain and swelling is there near the calf muscle. When it is after lifting the heavy object. So on examination there is a tenderness is there in the tendon. So tenderness is there in the tendon and limited movement but no joint instability. Movement is limited because there is the tendon is got damaged. There is no any joint instability, stable joint is there. Which of the following is the best describes this particular condition? So you can remember better when there is a damage to the tendon, what we can call, and there is the damage to the ligament, what we can call. So you can remember how we have to remember that is the strain we have. In the strain, we have the strain means we have the T here, that is the damage to the tendon is the strain. And in the sprain we don't have the, in the sprain we don't have the T. So the sprain means damage to the ligaments. Damage to the ligaments. Sprain is the damage to the ligament and the strain is the damage to the tendon. You have to remember for your exams because this will be very important for your exams. So here the tenderness in the tendon is there after leaving the heavy object. So that indicates there is the damage to the tendon, means this is the case of the strain is there. Very important. So dislocation means I told already from the joint the part will be dislocated, it is coming out. Fracture means there is a break in the continuity of the bone. Bone is damaged, a break in the continuity of the bone is called as a fracture, and a tendon is damaged, a strain, sprain means the ligament is damaged. I hope it is clear. And we have the very important golden words to revise here. What is the tendon? So here the Mycobacterium tuberculosis you can remember. Sir, what is the Mycobacterium tuberculosis, sir? That is the tendon means the structure which is connecting the muscle to bone. That is the muscle to bone connecting means tendon. Getting the point? So you can remember with the MTB Subbalakshmi. Okay, so that is the very important. Please do keep in your mind. So MTB. So that is the Mycobacterium tuberculosis, means muscle to bone connection is by the tendon. And remaining, so you can remember like B to B is the L. So that is the bone to bone connection is by the part we call as the ligament. Okay, so the part which is connecting the bone to bone is the ligament, and the part which is connecting the bone to muscle is the tendon. So where the tendon is damaged means we call this one as the strain, and the ligament is damaged means we call this one as the sprain. Getting the point? Yes, sir. So here strain, tendon injury, sprain, ligament injury. Okay, so what is the management of this one? This is the one of the 5-star topic you must and should remember, and from here you may get the question directly in your exam. So this is the direct question of your exam. Yes. So yes, beta, class will go till 10 to 15 minutes more. So if you are tired, you can go, no problem. Okay, so who all are interested, they will watch. Okay, yes, the rice is there here as a management. This is one of the very important concept where the looks simple but effective and important in the exam, and which will not comes as a direct question, it will comes as the indirect question. So like a patient is there who have fall down and he is having the like tenderness over the near the muscle. Okay, so near the muscle means which we have, so we have the like tendon, so the tendon is damaged. Okay, so what is the first nursing intervention? First is immobilize the body part. So they will give the immobilize the body part. It means we have to provide the rest to the that particular body part which is involved in the damage. Okay, so here's the very important point. The rights principle, it will works on the very important in the management or in the first aid of the our very important, what we can say, tendon injury. Okay, so that is very important. R stands here as the rest, which means avoid the movement of the injured part because it will further damages that particular part. I stands here as the ice application. Apply the cold compression. Sir, what is the timing? So in a 2 to 3 hours we have to apply continuously for the 15 to 20 minutes. And C stands here as the compression. That is the elastic band is to be used to compress the body part because we don't want the bleeding from there. And E stands here as the elevation. So that is the raise the limb above the heart level to reduce the bleeding. So this is the rise principle here we have in the maintain management of the tendon and the strain and the sprain. I hope it is very much clear to every one of you. Getting the points? Yes. So I hope it is very much clear. So next we have is the here the patient is on the skeletal traction. We have the patient on the skeletal traction. Question is very simple again. And for the femoral fracture, he develops the redness. So very simple question. Already discussed one. So just I want every one of you to choose the correct answer here. Okay. So here the patient is there on the skeletal traction. He is there, and femoral fracture is developed. Okay. At the femoral fracture, we have applied the skeletal traction. So remember, but it is not a skin traction. Focus. This is the skeletal traction. I told the image also I have drawn and pin also I have inserted. Or remember, image also we have drawn, pin also we have inserted. Yes. Yes. The patient is having the skeletal traction for a femoral fracture. So he develops now the redness he developed, the swelling he developed, the warmth he developed, and the purulent discharge. The pus is coming around the pin site insertion. What is the immediate priority nursing intervention? Better, that is a very important point you have to remember here. Immediate priority nursing intervention. We should not delay here. Immediately we have to inform to the physician and we have to document the finding, because this indicating the infection at the pin site care. So where the pin site we have inserted in that particular site, it is the infection. If we are neglecting this one, it will get converted into the osteomyelitis, that is the infection, inflammation of the bone plus bone marrow. So that is the osteomyelitis, what we can say. That one we don't want. So that is the reason here the tightening of the traction rope immediately, it is not going to be useful. That is not going to reduce the infection. Removal of the skeletal traction, that is also not going to be helpful. And notify the physician and document the finding, this is also correct answer. So here we are removing the skeletal traction is not nursing intervention, and like tightening of the traction rope is also not nursing intervention. So here applying the heat over the pin site also not going to be helpful here. So that is the, I am removing the option D also. The option C goes to the correct answer. Almost all you people given the correct answer. This is what I want every one of you. This is what you are preparing for. This is what you are consistently reading, revising, repeating. So this is what it will help you to choose the correct answer. This power, this dedication, this focus you have to have in your life to improve yourself, right? Yes, sir. So this is the correct answer. Who all given the option C as a correct answer? But most common complication of the skeletal traction. So where the skeletal traction, most common complication is the at the site of the pin insertion, there may be infection. So what is the priority if there is in the infection at the site of the care? So that is always and always. So we have to always focus on the prevention of this one. Provide the pin site care to prevent the infection. So if even after providing the pin site care, so infection even happened, you consider that time what we have to immediately without delaying. So if the infection sign is present, report early sign to the like orthopedician who is taking care of that particular patient. Otherwise it will get converted into the osteomyelitis. I hope it is very much clear to every one of you. Yes, yes, sir. So the next very important question is here, and here it comes to the end of the class. So please identify the image and choose the correct answer. There is an appliance is there which is shown in the image. So the appliance which is shown in the image is consisting of the two special shoes that are there and which is attached to the bar in between. So this is used in the correction of the club foot. What is this called as? So what is this? Is the image based question. So this is the IBQ for your exam. So please do focus. Yes. Here we have the two shoes and in between it is attached by the bar. So this is used in the treatment of the, or it is used in the management of the club foot. Yes. What is this called as? What is this called as? Yes, the Thomas splint or the baby splint. The baby, that is the Bowler Brown splint, the recently one, the most commonly used one in the hospitals. The baby splint or the Bowler's Burn splint. In the orthopedic ward, every bed will be having this one. So I will show that image. And the Thomas splint we have, and the pelvic harness we have. So what is the correct answer? And all are given the correct answer as option B. Your answer is correct. This is the DB bar. Okay, that is the Danish Brown bar. This is used in the treatment of the club foot. Okay, and pelvic harshness I have already shown the image in the developmental dysplasia of the hip. So that is, this is not a pelvic harshness. So in the developmental dysplasia of the hip, I have already told that this one we are using for the maintaining the abduction plus flexion of the hip. This is used in the developmental dysplasia of the hip. Already we have discussed. And BB Thomas splint I will show you. You can see here. So this is the Thomas splint we have, and this is previously most widely we used to use. Nowadays we have the very less use of this one. Okay, so this is Thomas splint we have here. That is mainly used for the immobilize the shaft of the femur fracture. Okay, so here we have the shaft of the femur. So the femur is got fracture, means in that one we have to immobilize that particular leg. We have to insert this Thomas splint, means this is the like a rod we have, and here is the round area. So that round area will insert here, and we will apply the dressing over this particular entire rod area, and from here we will apply the pulling force that is used in the traction. This is what we call the Thomas splint. Okay, yes. So next here we have the DB bar, that is the Dennis Browning bar. So this is used in the club foot. So you can see the images here. So club foot or the talus, we can say there is on the position of the foot is not in the proper position of the our leg. Okay, it should be varus, that is inward turn, valgus, that it may be outward turn, it may be a equinus where the plantar flexed, okay, or it may be a calcaneus where the dorsiflexed. So that one we will discuss here. Okay, so Dennis Broad, Deranis bar club foot is there. So this is very important. And here we have the baby splint or the bowler brown splint. Very few people know the full name of this one. So in the hospital, this one will be called as the give the baby, give the baby, give the baby, take the baby. That is the baby splint, baby splint, baby splint. That is the bowler brown splint is the full name of the baby splint. Okay, this is here we will use for this one is for the two things. One, we can keep the patient leg elevated also. We can keep the patient leg in height also. Another is we can apply the pulling pressure from here to this side. Okay, so this is a pulling pressure how we can apply here. Right, so two things. One we can use for the elevation of the foot. One we can use for the traction also. This is the baby splint we have here. Okay, this is used mainly for the in the fracture femur fracture, and it is allowing the limb to elevate and the maintaining the traction also. This is the baby splint. Okay, so you can see how we can keep this one here. The femur is got fracture, right? So here we are maintaining the alignment, and especially this is also prevents the foot drop also, because so here we are applying the traction to the especially the lower end of the our foot. Okay, it will maintain helpful for the maintaining the 90-degree flexion of the foot. Okay, so that is the very important. Getting point? Yes, sir. So this is the baby splint we have, and here we have the pelvic harshness. I already told this one. This is used in the developmental dysplasia of the hip. This is helpful for the two things. One is for the maintaining the hip flexion. Another one is for the keeping the legs abducted. So this is the pelvic harness. Already have told you one. Okay, so next we have is the Melvico brace. This Melvico brace is the image based question which may strikes in your exam. Are very important. I already one time asked in the previous exams. That's the Melvico brace. You can see here. So this is used in the scoliosis. What is the scoliosis, sir? When I have see the patient from the posterior, means from the back side, the vertebrae is the yes means side to side it is curved. So side to side curvature of the vertebrae, we call that one is the scoliosis. In the treatment of the scoliosis, we can use this one. This is the Melvico brace splint. So this one we are using in the treatment of the scoliosis. Okay, yes, so this is very important to be keep in your mind. And next here it comes to the congenital club foot, or that is the talus we have here. So the very important one, remember beta, from the talus, just the terminology you know means you can play the complete game in the exam. So just by the terminology, remember I will teach that one in a very easy manner, so you will enjoy that one. Okay, talus means we also call this one as the club foot. Okay, so that is the a congenital deformity is there in which the foot is abnormally positioned in relation to the leg. Okay, so this is our normal leg means this is our normal leg means this is how our normal foot should be positioned normally. So if this particular foot is inward rotated, outward rotated, or plantar flexed or dorsiflexed excessively, this is what we call the mal-positioned foot in axis of the leg, or the club foot or the talus. Getting? Yes, sir. So this is the most common type of the talus we have is the talus equinovarus. What it means, sir? So but here we have the words, you can see the three very important terminology you have to understand here. That is the varus. Varus. It means inward turned. Means the foot is there. Okay, this is my body part. It is turned inward. This is the varus. If it is turned outward, that is the valgus. If it is like there is the plantar flexion, we call the equinus. And if it is foot is completely dorsiflexed, and while walking we are keeping our heel bone on the ground, that is the calcaneus, because this heel bone we have in the foot, that is the bone name is the calcaneus. Okay, so here we have the varus means, what is the varus? Varus means inward, valgus, valla, I don't want. Valla means that is the I don't want. In a Kannada we have the one word, that is the valla. Valla means I don't want, right? So I don't want means you go outward. That is the very simple thing. Okay, valgus here means that is the outward. Remember, varus means inward, and equinus means that is the plantar flexion is there. So that is the toe is pointing downward. That is the equinus. Okay, so please do remember these three words, right? So now you understand about this one. The most common type of the We have, just give me 2 minutes. Yes. So Talip's equinus is the always most common type of the Talip's we have. Okay. So Talip's means that's the congenital club foot we call as the Talip's. Equino means that is what we can say plantar flexed, and varus means that is inward flexed. So plantar is flexed and that is inward flexed. So that is the varus. Okay. So this is the most common type. Foot is plantar flexed and heel is inverted. So that is the varus we can say. That is the most common type. And we have the Talip's calcaneus. So beta, here we have the a very important word. So that is the bone we have in the our heel, that is called as the calcaneus bone. So what is the name of this bone? So the bone which is or the heel bone we also called as the calcaneus bone. Okay, that is the calcaneus bone. So when the like dorsiflexion is happen hyperextended, and the only while walking we are keeping the calcaneus part, that's the heel part on the ground, that's what we call the Talip's calcaneus. So this Talip's calcaneus is there means the completely hyper extended or the dorsiflexed, what we have is the foot, and the only this foot like what you can say the heel is landing on the ground, so that is what we call the Talip's calcaneus. So here heel is everted, that is the valgus is there, and the foot is completely dorsiflexed is there. That is the Talip's calcaneus. Okay, so that is the calcaneus we have. Okay, so calcaneus means, so that is the heel is inverted also, and the heel is like dorsiflexed foot is also there here. Okay, and the child is walking on the calcaneus bone, which is the very important. These are all the image based questions you may get in your exam. Next we have the Talip's equinus. So equinus means I told that is the like plantar flexor is there. So while walking, the child will walk on the toes. Okay. So while walking, the child is walking on the toes means that's the equinus. Okay. That is the plantar flexor foot we have. And the Talip's valgus. Valgus means I told that is the valla. That is I don't want. Means that is the foot is going outward. That's the valgus. And the varus means that is foot is turned inward. So this is the varus. So these are the very important points you have to keep in your mind better. So from here you may get the questions, and in the initial treatment we give is the PSC we will do. So that's the Pronis serial casting we will do. So that is the Ponseti serial casting we will do, means one by step means the dorsiflexion also there and inward also turned. First we will make it correct direction, then we will bring it. So the Ponseti serial casting we will do. After that we will apply the Danish brownie bar we will apply. So this is also very important. I hope it is clear to every one of you. Okay, and who all are become a part of the our crash course sessions and the full course for the Norcet you want, so that you are preparing for the Norcet 11. So you want the each and every topic complete clarity of the concepts. You can go for the our A1 plan here, which is having the 700 plus the best quality lectures with the complete clarity of the concept, images, everything that is required for your success. So that is there in the A1 plan. So from the very basic to very advanced, you can prepare through this one. And we have the crash course for the Norcet 10 aspirants who are appearing in the next Norcet, where this particular class also will be provided with notes and MCQ practice on this one. Okay, so along with this one, you will get the 100 hours. That's the 50 high yield, very high yield topics like a CPR, ECG, and not only the class, not only the MCQ discussion, you will get the MCQs for the practice, that is near about the 10,000, or the you will including the live test, it will be around the 50 to 20 like 20,000. If you are attending only live test plus the subject test, that is enough for your Norcet. Okay, so don't go for all things. Now you don't have the time. Just attend the subject wise MCQs. Now we have studied the entire skeletal system. So since from the last 2 days, 3 days, now skeletal system is over here. So each and every point we have covered. That is the golden point in the only 4 to 5 hour lecture. That was the very important for our exam. Okay, so this class plus notes plus MCQ, everything you will get in the crash course. Okay, and we have the rank booster test also, that is including the super 60 test plus the 20 mains test. The total 80 tests you will get for the duration of the 4 months. After 80 tests, it will get closed. That is the rank booster test or the super 60 test. So here you can see the Norcet 10 crash course we have is the what are the things I told here. The 100 hours lectures with the PDF notes of that one, and very important high yield topics only covered in this particular 100 hours lecture. There is no any faltu thing. Only high yield, very important classes only provided. And the 50 days classes, you have the important MCQ plus golden point revision classes. These 3 classes of its PDF notes and MCQ practice, and in this one you will get it. And the super 60 test series, that is the prelims, 60 prelims pattern tests you will get, and the 20 mains pattern live test you will get, and the 10,000 plus MCQs for your practice you will get, and extra 45 RRB test paper you will get in this particular crash course. That is the Norcet 10 package what we have here. Okay, this is for the validity of the 4 month, and this is starts from the date of the your purchase. Means you are starting today, so it will be 4 months up from the today. Okay, so that is very important. Next we have the plan even what I told you here is, so that is from the very basic to very advanced preparation. That is the plan even basic to advanced preparation. 700 plus recorded lectures as the very best quality without keeping a single doubt. Everything from the very minute to very advanced we have cleared with a very proper structured content, and each and every topic. So for example, you have now studied about on the CPR video you have seen, you consider. So dedicated test on this particular CPR. So you will get the 30 MCQ, 20 MCQ, 3 tests are there, 3 separate tests are there, so that you can watch the class, you can understand the concept and practice the MCQ, and definitely from this bulk only you will get the MCQ directly in your exams. So this one you are doing for the next 6 months or for the Norcet 11, means you are easily and very easily you can cover the entire concept, and you are very easily you can cover the entire syllabus, and you will very easily and confidently will attend the Norcet exam here, and you will clear in the Norcet 11. And now you don't have the time, so you can now go for the your very important Norcet 10 crash course. Who are preparing for the Norcet 10, go for the crash course. Who wants to prepare from the very basic, recently passed out students, BSc nursing students recently passed out, and who don't have the clarity about the basic things, so just go for the A1 plan and start your preparation. Rate will be very low, very minimal, and you will surprised by seeing the rate. So in this low cost, we are giving the such a high yield and very important and the best quality recorded lectures. Okay, so the subject wise MCQ also you will get here. So in the A1 plan, the very important. So this is what we can say all in one plan. Okay, super 60 already have told. And sir, can anything will we get free, sir? Yes, every Sunday you will get the Norcet factor, Norcet pattern all India free Sunday exam. Every Sunday will get, where you will get the same to same pattern Norcet pattern exam will be free in the app. So just what we have to do is download the Master Nursing Classes app. The link is given in the our very important comment box and in the description box both. So thank you so much for watching the class here, and I hope you are preparing well and everything is going fine. Don't take extra stress. Be cool, calm, relax. And now this class we will get in the A1 plan, A2 plan both. Okay, so again, don't want the watch the class, just revise the notes which I am uploading in the A1, A2 plan. So thank you so much for the watching the video till here. Bye bye, take care. We'll meet again in the next class. Tab tak ke liye Jai Hind, Jai Bharat. Thank you everyone. Don't forget to download the Master Nursing Classes app and attend the Sunday free exam every Sunday. Bye bye.